Well, good morning. My name is Joe Cressy, and I'm the chair of the Board of Health. Our board secretary has confirmed that we have quorum, so I'll call meeting 27 of the Board of Health to order. Welcome, everyone. I know this is a quick turnaround as we met a mere 3 weeks ago. Today's meeting is being held by video conference. City staff are also connecting to the meeting by video conference. As City Hall remains closed, the public will continue to participate electronically and can watch the meeting streaming live on YouTube at youtube.com/Toronto City Council Live. As always, I ask everyone for their patience with any delays and technical issues, and that includes my own, as I am working remotely and having to flip across an iPad screen to see you. So I apologize in advance for any issues on my end. We do have a number of registered speakers here today. The clerk staff have connected all registered speakers to the meeting by audio. Although we are meeting in different locations and meeting remotely, the Board of Health would like to acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. As I begin, are there any declarations of interest under the Municipal Conflict of Interest Act? If you have an interest, if you could just unmute your mic and indicate so. Okay, seeing none. Next, we do need a motion to confirm the minutes of our last meeting from March the 22nd, 2021, moved by Councillor Ainsley. Thank you. All those in favor, by way of a show of hands, opposed if any, that carries. We're going to proceed now with the agenda review. We have 2 items on the agenda, and there is a brief new business item as well. The first item is HL 27.1, response to COVID, April 2021 update. We do have a detailed staff presentation as well as registered speakers. So that will be held down. The next item is HL 27.2, advancing Black food sovereignty. There is a staff update report with a recommendation, and we do have 2 registered speakers on that. So that will be held down. And to members of the board, the list of speakers, I should note, who have registered to speak is available online, and you can see that list. And then we have finally a new business item, which is a verbal update on the Association of Local Public Health Agencies from our board member who sits there on our behalf, Director Mulligan. And so I'd ask, I have a letter here simply for Association of Public Health Agencies for Director Mulligan to provide us with an update. Formally, we need to add that as a new business item. So I would ask for a motion here to move that as a new business item so that Director Mulligan can give us that update. All those in favor, opposed, if any, that carries. Okay, this will bring us right back then to the top. We will kick this off on item HL 27.1. This is response to COVID. We're going to begin with a staff presentation. We have a rather detailed presentation from Dr. Davila and team. Then we will move to speakers who have registered before we then take it into committee for questions. So, Dr. Davila, it's been a busy 3 weeks since we last met. The world has changed on a daily basis, and I know you and your team have fought tirelessly throughout, so I turn the floor over to you.
Thank you, Mr. Chair, and good morning all. We should have a slide presentation which should be brought up on screen in just a moment. It has indeed been a very, very busy 3 weeks, and I would argue the changes seem to come on a hour by hour basis, even more so than on a daily basis. So just waiting for our slides to come up. But perhaps what I'll do is I'll start going on the presentation so as not to lose any time. In the first instance, as I often do through these presentations, we provide you with an overview of the status of the epidemic. Thank you so much, of COVID-19 here in Toronto. If we move to the next slide. Actually, you can move 2 slides ahead. I regret to inform you that we have surpassed 125,000 cases now in Toronto. You're familiar, I'm sure, members of the board, with this slide. I've presented something similar to this on a number of occasions. I should also update you that today we are reporting 1,296 cases, and unfortunately as well, 44 new admissions since the previous report yesterday to hospital, 5 new admissions to ICU, and unfortunately 5 new deaths as well to COVID-19. So our situation here in the city continues to be quite stark in terms of COVID-19. We are firmly in the grips of this third wave, and it is wreaking havoc certainly in our city. We turn to the next slide. This is depicted on our monitoring dashboard. And just to give you a sense as to how much this has changed in the 3 short weeks since we last met, starting from the top left, you can see new COVID-19 cases, 7-day moving average, we're now reporting 931. When we met 3 weeks ago, this figure was 432. That's a 116% increase since we last were gathered around this teleconference. The same can be said for new hospitalizations. The 7-day moving average there is 34.6. When we last met, this figure was 13. That's a 166% increase. And moving across the slide, the active daily COVID-19 outbreaks in institutions figure. Currently, today, we're reporting, or as of April 9th, I should say, 33. The last time we met, this was 19. So you can see that our indicators are clearly not moving in a positive direction. And we are seeing, challenges related to COVID-19 and its transmission. Our current effective reproductive number is above 1. It's now at 1.07. It was above 1 the last time we met, and an ever so slight decrease from then, but still above 1, which is an important piece, given that means that the outbreak continues to grow. And as well, on the bottom right hand of the slide, you can see that our percent positivity is now sitting at 8.4, and that is an increase from the last time we met. That figure when we met in March was 5%. And we continue to see high testing rates. So this is not a reflection of a change in testing rates either. What I can tell you is that this has all been driven by the variants of concern, a subject that we have discussed at this table before. And what we're seeing here effectively is what many of us had worried would happen with regard to the variants of concern if they took hold. And not only are these variants of concern more transmissible as evidenced by these data, we're also seeing that they're causing more serious illness, leading to hospitalizations and deaths. And that takes us then to the next slide. The next slide depicts some data and an analysis that's been done by the Ontario COVID-19 Science Advisory Table. They conducted this analysis at a province level, or a provincial level, I should say, and they've done a similar analysis looking specifically at Toronto. So I realize that there are a lot of numbers and figures on these slides, or on this slide, I should say. But, effectively, high-level summary, what we're seeing here are the results of a retrospective cohort study of about 10,519 people in Toronto who tested positive for COVID-19 between February 7th and March the 16th. And what it did was looked at people who had a variant of concern COVID-19 infection versus those that had a COVID-19 infection that wasn't a variant of concern. And the high-level summary is at the bottom in that yellow box. What they found was that infections due to variants of concern were associated with a 91% relative increase in COVID-19 deaths and a 36% relative increase in COVID-19 hospitalizations in Toronto. So yes, with VOCs, or variants of concern, we are seeing a more transmissible version of COVID-19 relative to what we had experienced previously in this pandemic. And not only is it more transmissible, but we're finding that it's having more significant impacts, whether we're looking at this in terms of hospitalizations or deaths. Next slide. Now looking at the longer term projection, or at least the projection for several weeks out. Unfortunately, looking at our data, we are on track to see up to 2,500 daily cases by the end of April. And this is taking into account, yes, variants of concern and their transmissibility, but as well vaccines. So looking at the top part of the graph, as you can see here, if transmission stays the same at the current level that it is now, we can actually expect to see over 2,500 daily cases, or about 165,000 cumulative cases by the end of April. So this is significant. You may recall in our previous wave 2, the highest daily number of reported cases was 1,642. So this is clearly a more significant figure at what we're expecting, a higher up to 2,500 daily cases. And in the bottom graph, you can see that even if we are able to decrease transmission by 10%, we can expect to see similar, a high level of daily number of people in hospital. In fact, commensurate with what we saw at the week of wave 2, which is around 765 daily cases. And we can expect to hit that at about mid-May. So altogether, this says that right now, what we can anticipate is that this third wave is likely going to be the worst that we have seen thus far over the course of the pandemic. And as I've mentioned already now a couple of times, this is due to increased transmission and increased severity associated with that B117 variant of concern, which is now the dominant strain here in the city. Turning to the next slide. We've learned, though, over the course of the past several months, even with the variants of concern, that our ability to reduce transmission actually does rely on our ability to maintain distance. And the ultimate form, of course, of maintaining distance is staying home to the greatest extent possible. That's what allows for, the most reduced form or amount of interaction with people other than those with whom we live. And what we have seen recently is reduced mobility overall in the city, but not equally experienced in all parts of the city. So there are, clear differences as indicated here on this particular slide. This takes a look at, and this is data that you have been presented before at this table, looking at the proportion of device check-in time at home. So the amount of time that cellular devices are actually in the home location, which gives you a sense of mobility. The higher the check-in time, the more time at home, therefore the less time spent out and about, and of course, vice versa. I'll just remind everyone that these are premised on aggregated and anonymized data, so there isn't anything by way of personal information here that is divulged or made available to us, but it does give us very important information indicating that there are portions of the city where in fact reduced mobility is being observed, particularly as over the last couple of weeks, as the province has moved increasingly towards shutdown and more restrictive measures. But unfortunately, there are other parts of the city where clearly mobility continues to be at higher levels for reasons that we can certainly hypothesize about, but can't confirm fully. But this is effectively what we're seeing right now. It is important to note, of course, that we're seeing more mobility as depicted in the orangey shades on this map in the northwest of the city in particular, which we know has actually had disproportionate impact of COVID-19, whether we're talking about cases, hospitalizations, and deaths as well. Turning to the next slide. These are also the latest information that we have in respect of how COVID-19 is impacting our city and different groups, particularly related to income and to racial background or ethno-racial background. Just at a very high level summary, and these data are put on our website on a regular basis, done on a monthly basis, in fact. So the most current data that we have available to you at this point are as of February 28th of this year. High-level summary is provided on the points on the left-hand side of the slide. We know that a total of 76% of cases as of February 28th are racialized, and is depicted on the graph and written on the left-hand side of the slide. We know that our Latin American populations have the highest monthly reported case rates and, unfortunately, the highest hospitalization rate as well. I think it's very important to note that we see that continuing pattern with respect to income differentials. Even after adjusting for age, the hospitalization rate in the lower income segments of our population was 3 times as high as the rate for those who were not part of that lower income groups. So again, we're continuing to see these important divides and demarcations within our city and differential impact of COVID-19 on different subpopulations within Toronto. Turning to the next slide. The next section of this presentation focuses on public health measures. We can go straight to the next slide. Very busy week, or week to 10 days really. You'll recall that on April 3rd, the province did move such that the entire province was put into the shutdown category of the Reopening Ontario Act. A few days later, the province formally declared a third provincial emergency. And effective April 8th, what that meant was that there was a stay-at-home order put into place for 4 weeks. This closed in-person non-essential retail and put some restrictions on big box stores such that they are only able to sell essential goods. And there were some restrictions put into place as a result of these moves made by the province to residential evictions as well. Turning to the next slide, you'll see that it was also busy for us here at the city. It was with a very, heavy heart that we found ourselves in the position, and I then subsequently had to issue a Section 22 order to move all Toronto schools to remote learning effective April 7th and until April 18th. This was because of all the community transmission that we were seeing within our city, as depicted on the monitoring dashboard and through the numbers that I've provided to you. The variants of concern are creating a significant degree of COVID-19 transmission here in our city, and our schools are mirrors or reflections of that which is happening in our broader community. As we saw risk going up in the community, we also saw that risk was increasing within the context of our schools. And we really felt that it was important to make a move to prevent the schools from going into a circumstance where we could not support their safety or ensure that they were as safe as we would like them to be as in-person learning environments. So unfortunately, we were in the position where, given the spread and the risk associated with these new variants of concern, the order had to be issued. And we are constantly monitoring the data. There are still a number of staff at Toronto Public Health, even as the schools are now in their spring break period, still a number of case follow-ups and activities and investigations that need to continue. And we're monitoring our data. So at this point in time, an extension of the order is certainly, under consideration, but it will all be premised on what we're seeing in terms of our data and our understanding of what the risk is in our community and therefore in our schools. But there is no question that we recognize at Toronto Public Health that there is great benefit to having in-person learning. And we have taken very seriously the work that it takes in order to sustain in-person learning to the greatest extent possible. The evidence certainly supports that there are many benefits to maintaining schools open to the greatest extent possible. Of course, that still needs to be done in a manner that's safe. And we firmly believe, in accordance with this evidence, that schools should be the last to close and the first in our communities to open. So I can assure you that that decision was not taken lightly. Turning to the next slide, we're now going to focus a little bit on our vaccine implementation activities and provide a vaccine update. So looking at this, we know that we are continuing to focus our efforts in accordance with the best available science. The focus started off and continues to be on age and high incidence areas in order to really address these transmissible variants of concern and ultimately to reduce morbidity and mortality associated with COVID-19 infection. So as you may recall from previous presentations that have been made to this board, there were, or vaccination activities, I should say, are being done in accordance with the provincial prioritization framework, which is occurring in phases. Phase 1 being obviously the first, and started off with long-term care homes, high-risk retirement homes, and First Nations elder care homes, and staff, essential caregivers. And I note that residents of those facilities were also included in Phase 1. So we're continuing to provide vaccine activities towards these Phase 1 groups. Healthcare workers as well, people aged 80 years of over, Indigenous adults, adults recipients of chronic home care, and shelters was actually brought up in terms of priority and was included in the Phase 1 groupings here in Toronto. It was not actually in the Phase 1 group under the provincial prioritization framework, but because of our circumstances here in Toronto and some advocacy that was done with the province, shelters, both those using shelters and those working within the context of shelters, were provided an opportunity to be moved up into the Phase 1 grouping. Turning to the next slide, the province actually moved into Phase 2 of the COVID-19 vaccine distribution plan. This is their plan. And during Phase 2, there are a number of groups that are added over and above those that we've just described in Phase 1. And the original Phase 2 proposal for the province included older adults between the ages of 60 and 79, people with specific health conditions and some of their primary caregivers, people who live and work in congregate settings, and again, primary caregivers for those individuals. There's a focus on hotspots, particularly those that have high rates of COVID-19 transmission. And as we look at it here, we're also looking at hospitalizations and deaths as part of those data. And as well, the Phase 2 plan of the provincial prioritization framework does include a number of workers who cannot work from home. So this again is the Phase 2 that was just formally launched by the province last week. Turning to the next slide, you know, it has meant that there have been a number of different populations and subpopulations that are now eligible for vaccine. And I recognize that, you know, the information is changing relatively quickly. So staff at Toronto Public Health have put together this slide to help articulate where we are in Phase 2 of the vaccine rollout. And this is as of April the 9th, which are the categories of individuals that we're talking about that have are now eligible under Phase 2, where they can access vaccine, and what the estimated timeline is for those individuals to actually get covered as part of Phase 2. So you can see there are quite a number of different settings, everything from city-run clinics to hospital clinics to mobile clinics and pop-up clinics. And as well, there are pharmacies and primary care who are engaged in the administration of the AstraZeneca vaccine. That has been continuing on. We've got those with chronic conditions largely being managed through our hospital partners. Congregate settings are also being addressed by different partners, some of whom are operating mobile clinics. And where we can, we are working with administrators of congregate settings to try and do group bookings where possible, or to facilitate the ability of those in congregate settings to actually receive vaccine at some of our city-run clinics. Hotspots obviously has been the subject of much conversation in the media over the last couple of days. Depending on which method or channel of vaccine access, the ages do vary. If you come to a city-run clinic or a hospital clinic, it's 50 plus. For mobile clinics and pop-ups and hotspots, it's 18 plus, and this has just started. And with respect to essential workers, those who cannot work from home, we know that many of them will be able to access through our hotspot strategy, but we are also exploring some workplace-based pilots this month in concert with our Toronto vaccination partners, our hospital and Ontario Health Team partners, to see what additional benefit there might be from participating in workplace-based pilots over and above focusing on a hotspot strategy, which gets vaccine to essential workers where they live and also provides vaccine to their households. So turning to the next slide, a bit of an update on the city-run clinics. Just last week, an additional city-run clinic began operations at the hangar in North York, and it has been quite busy since its opening. And we are launching the 3 remaining city-run clinics that have yet to open. They are opening in just a few short hours, in fact, at Carmine Stefano Community Center, Cloverdale Mall, and North Toronto Memorial Community Center. As noted at the bottom of the slide, all 3 of these sites are opening completely booked. And we're pleased to see this and certainly pleased to see the high level of community support for these clinics. The next slide just actually depicts where these new clinics are specifically on the map, and also it gives you a sense as to where the other clinic locations are, the ones that have already been opening. Or that have already been open, I should say, and operating. And you can see that at the bottom of the slide, there is a link to the interactive map depicting these clinic locations available online. Turning to the next slide. Now let's look at the specific progress that has been made over time in our vaccination campaign. So as of yesterday at 3 p.m., the total number of doses administered at all Toronto sites, regardless of which channel, was 758,882. And if you look carefully at the graph, the upper part of the graph shows you the doses that have been administered since December and up until early April. The bars in green depict first doses, the bars in blue depict second doses. So you can see what the activity has been over the course of the last few months now. In January, late December, I guess I should say, and throughout January, there was a fair amount of activity. You can see the green bars start to peak up there. And that was the activity that was happening within long-term care and retirement homes in particular, and as well for healthcare workers who were in the highest risk situations related to COVID-19 exposure. And then for that period of time that's depicted there between late January and late February, you can see that a goodly number of the doses that were being administered were second doses to those high-risk populations, those in long-term care homes and retirement homes, and as well the highest of the high-risk healthcare workers. As we have been able to ramp up city clinics, we started in mid-March. You can see towards the right-hand side of the graph that the green bars then really start to pick up. And you can see that the 7-day moving average on doses really starts to pick up as well as we move into March, mid-March, when we started to open our own mass immunization clinics, and throughout the rest of March and into early April, as more and more clinics, regardless of whether they're mass immunization mobiles or pop-ups operated on the part of our hospital partners, as well as their own fixed clinics, really started to ramp up operations. You can see that the dosing really does start to increase towards the right-hand side of the graph. So certainly happy to see that so much progress has been made in vaccination over just a few short weeks' time when you look at it in the grand scheme of things. Turning to the next slide, to give you a sense as to the vaccination rate of current eligible age group bands. Here you have a sense, these are data as of April the 8th, in the morning of April the 8th. Again, lots of focus on those older age categories, given what we know of COVID-19 morbidity and mortality. And you can see that actually in a relatively short period of time, significant coverage has been provided to some of our highest risk groups based on age. And we're certainly pleased to see that. We're not stopping. That does continue, that work continues on. But I did want to call your attention to the progress that has been made thanks to the efforts of so many people working towards getting vaccines out and into arms as quickly as possible, but also focusing on making sure that we're getting it into the arms where we are most likely to see the benefit, not just at an individual level, but frankly at a community level as well. Turning to the next slide, we do have some challenges that we need to address, and it is clear that there are coverage differences with respect to vaccine throughout the city. And unfortunately, what we're seeing is that those neighborhoods that currently are experiencing the lowest coverage are continuing to have, a reduced level of growth in coverage, even as we're making opportunities to vaccinate more and more available. So here you have a depiction of those neighborhoods that have the lowest coverage, those that have the highest coverage, and the change in coverage that has occurred in these areas over the past 2 weeks. So there is certainly work to do, and we're thankful that we have our colleagues throughout the city, and most notably our colleagues at Social Development, Finance, and Administration, who have worked very hard to bring on a number of community agencies, and that work will soon be launching in earnest, such that we can work better with communities that really do need to see better coverage of vaccine in concert with trusted partners, trusted community agencies that are on the ground. This is not unnoticed by us, and it is something that I can assure you that the team at Toronto Public Health is actively working on in concert with our fellow city partners and as well our community partners throughout the city. So turning to the next slide, it just highlights the importance of why we need to get to these neighborhoods. We know that you can see on the bottom right-hand side of the slide, the areas of the city where current activity, case activity and COVID-19 rates are the highest. They're the darker colored neighborhoods or darker shaded neighborhoods within that map on the bottom right-hand side. Conversely, we see where the vaccination progress is, or how vaccination progress is playing itself out across the city. And unfortunately, the areas that have the highest rates continue to have amongst the lowest vaccination rates as well. So our work is cut out for us, but I can assure you this is not going unnoticed by us. And we are absolutely committed to working with city partners and community partners to rectify this as soon as is possible. I do think that it's important to note that we are trying to use all of the channels available to us, mass immunization, mobiles and pop-ups together. And I think it's important to note as well that in concert with our hospital and Ontario Health Team partners, we have committed together as a team to focus resources on those areas of the city, and I mean vaccination resources in particular, to focus those resources on those areas of the city where it's needed the most, so that we can actually help provide protection to individuals in those neighborhoods, and then by extension, provide better protection to the entire city as a result. So next slide. Just to give you a sense as to what is happening amongst Toronto residents, these are data as of April 8th. We know that the total Toronto residents vaccinated, total doses administered, I guess I should say, to Toronto residents as of April the 8th in the morning sits at 601,548. And as you saw on an earlier graph, we're seeing that continued rise in progress as we move in time, as more vaccine and more vaccine channels have been made available. So I think it's really important that those around the Board of Health table or teleconference are aware that there is significant capacity amongst city and hospital partners in terms of the ability to actually administer vaccine. The major issue right now that we have is that there is not as much vaccine as there is capacity to deliver those vaccines. So this is an issue that has been a challenge. Once we, now that we've got all 9 of our clinics, and in just one short hour, we'll have all 9 clinics fully operational. Our hospital partners are also busy operating their clinics, their fixed site clinics, and as well in concert with Ontario Health Teams are actively operating mobile clinics and pop-ups around the city. So we would like to make use of all these channels together as the vaccination partners across the city. The key thing is that in order to fully utilize the total capacity that the entire system has, we do need more vaccine. I can assure you that at present, certainly on the part of the city-run clinics, We are not operating at maximum capacity simply because there are not enough vaccines to allow for that full on capacity to be opened up for use and for administration of vaccine. So turning to the next slide, it's with all of this in mind that I have some particular recommendations to make to the board at this time. First and foremost, I would recommend that the board request that the relevant the higher levels of government prioritize and increase Toronto's COVID-19 vaccine supply. This is fundamental towards reducing the risk and the spread of COVID-19. And I think that this is in order to allow us to actually meet the needs of eligible populations under the phase 2 of the provincial vaccine distribution plan. In order for us to actually discharge our obligations, we do need more vaccine so that we can, in a timely fashion, provide vaccines to all those who are eligible here in Toronto. My second recommendation is that the Board of Health urge the Government of Ontario to decrease the risk and spread of COVID-19 further by prioritizing vaccine registration for Toronto's highest risk hotspot areas. We know that there are certain areas of the city that are more disproportionately impacted by COVID-19 and have more COVID-19 activity. It is in keeping with the science that we focus our activities on vaccine in those areas where they're likely to deliver the most value for the resources deployed. So that would be my second recommendation to the board. I think that takes us to the end of the presentation. Mr. Chair, if I may just take a few moments, we find ourselves here on April 12th, a month and a bit after many of us in Toronto Public Health started responding to this pandemic. In the first part of the pandemic, it was largely around case management and contact management and outbreak management and IPAC, I should not speak in acronyms, infection prevention and control advice to many partners all over the city. We are now continuing to do all that work at unprecedented levels of COVID-19 cases, and at the same time helping and supporting the largest vaccination effort ever undertaken in this city and in the country. All I can tell the members of the Board of Health through you, Mr. Chair, is that, we have many people to thank: city partners, our hospital partners and healthcare partners, Ontario Health Team partners, just too many to thank and list. So I'll just leave it in those broad categories. But I would be remiss if I did not acknowledge my Toronto Public Health team. They continue to continue to dig deep when there isn't anything left to dig. And I'm indebted to them in ways that I can't even describe. So I just wanted to acknowledge their efforts, despite the many, many hardships that the pandemic has presented over the last many, many months now. So with that, Mr. Chair, I will turn it back to you, and we'll go from there.
Thank you, Dr. Davila, for the comprehensive presentation, as chilling as it may be. We're now going to move this to open it up for registered speakers, of which we have a number. And so I will ask the recording secretary to prepare to open up the lines. Our first deputant on this item is Amir Rushan. And so just before we begin, I just want to note for registered speakers that under our Board of Health procedural bylaw, we do ask that public presenters not use offensive language and speak only about the subject on which the board has invited them to present today, and to obey those bylaws, and we will be enforcing those here today. With that, I will open it up to Amir. Amir, do we have you on the line?
Hello, this isn't home with the city clerk's office. Amir is currently not connected.
Okay. I will do a second call just to see if we do have Amir. I'll do it. And He's not, so he hasn't dialed in. It's not he's having a problem connected. In fact, he hasn't dialed in. Is that right?
That is correct.
Okay, so we'll come back if he does join, but moving forward, our next speaker is Tommy Taylor. Tommy, do we have you on the line?
Tommy Taylor is currently connected and their mic is unmuted. Tommy Taylor, if you could say a few words, please.
Tommy, if you're there, your mic is unmuted. Do we have you on the line? Nahom, I'll just check again. The mic is unmuted. We do have him on the line.
That is correct, Chair. Tommy is unmuted and he is on the line.
Tommy, do you want to try again? Sorry, I know these virtual meetings are difficult for this. Okay, what we'll do is we'll hold Tommy down then, because clearly he has joined the meeting, and we'll try again, and I'll come back after the next speaker. So Tommy, if you're listening and having technical challenges, we will, or if it's on our end, we'll come back to you momentarily. Our next speaker we have registered is Kathy Crow. Kathy, do we have you on the line?
Yes, I'm here. Good morning, everybody.
Oh, good morning, Kathy. Great, so it is working. Kathy, good to have you. You know the drill. You'll have 5 minutes when you're ready. I'll give you a heads up just as we're approaching 5, but thank you for being here.
Thanks for the opportunity. So third wave COVID has presented as a predatory attack on people who are vulnerable because they are unhoused. There have been 41 shelter outbreaks since January this year. And on Friday, there were 17 outbreaks and 354 COVID cases. At least 15 shelters are on their second or third outbreak. And shelters are not just dealing with 1 or 2 cases. Frequently, the numbers are 16, 25, 56, 80, demonstrating both the heightened ease of spread, but also the total inability to protect people in congregate settings. And cumulatively, there have been 107 shelter outbreaks since the beginning, with over 1,300 people infected in the shelter outbreaks. I know I speak for many when I say it's concerning that we do not hear regular updates at city briefings on COVID and the unhoused population. We know that COVID in this population goes beyond the shelter numbers. Outbreaks connected to drop-ins, which function as day shelters, are not tracked. COVID cases in people surviving outdoors, such as in encampments, are also not tracked. Why is that when we know the huge risk? In the first wave, homeless people were 20 times more likely to be hospitalized, and those numbers have been, that research has been reported quite widely. It's also concerning that the number of staff who are infected in shelters is not separated out from the shelter outbreak numbers. And this is a health and safety issue for workers that we should know about. The capacity at the Recovery Hotel for homeless people has been stretched for weeks. This led to homeless people with COVID and close contacts to shelter in place, in all cases without adequate health and shelter staff support to support their isolation. Many of us have pressed to SSHA the need for another dedicated recovery site and for the city to request the formal help of the Ontario Red Cross, Doctors Without Borders, and/or the medical component of the armed forces to support proper isolation, infection control, and follow-up. This has to be hands-on, not just in the form of a memo to encourage people to wear masks. We are alarmed at the snail pace of vaccination rollouts, given the congregate and risk in hotel shelters. Several suggestions would be to provide more substantial incentives, publish the vaccination schedules, partner more effectively with community groups to support vaccination uptake, and appoint a homeless vaccination czar to coordinate the effort. One-day clinics in a shelter should be followed up with an easily accessible community clinic, such as at the St. Lawrence, John Innes, or Regent Park Community Center. Those are M5A postal codes. In closing, aerosolized COVID transmission should be a stark warning that all homeless people should be relocated from congregate shelter sites as soon as possible. That means you need more hotels and more rent supplements for housing. Infectious disease doctors are now recommending N95 or K95 masks when people go on the TTC or in grocery stores. Cloth masks are not adequate. Surely that is a red flag for congregate shelters. Get people out of them and don't plan to decant hotel shelters back to congregate sites when this is all over. I have to wholeheartedly agree with Dr. Kashif Pirzada, an emergency physician in Toronto, who said, quote, "In Canada, we've always been reactive. We've always done things a little too late, a little too little." So I'm here today to add to the urgency that we heard in Dr. Davila's presentation, and you'll hear, I'm sure, from some other frontline workers. Thank you very much.
Thank you, Kathy. Before you leave, let me open up the floor to see if there are any questions from members of the board for Kathy. Seeing none. Kathy, thank you very much.
Thank you.
I believe that we have resolved the technical issue for Tommy Taylor. Tommy, let me just ask Nahom to connect you again. Tommy, do we have you on the line this time? My apologies for earlier.
That's all right. I think it's a success. So these days of Zoom and WebEx and everything in between, I'm just happy to be connected now. And yes, thank you everybody for having me here. I'm Tommy Taylor. I'm a frontline shelter worker here in the city of Toronto. I've done our long stay shelters. I've worked out of the cold before, respites, 24-hour drop-in shelter hotels. You provide a service in this city for homeless folks. I've worked in it. And I'm very, very concerned for me and my colleagues and the clients that we serve. It's a year ago, things went really sideways when COVID hit and we had to do emergency social distancing in spaces. There was the opening of the community centers. Frontline workers were trying to create isolation spaces in shelters and drop-ins, just things we are not trained to do and completely not appropriate for us to do. And it's just so wild sometimes that we're here a year later, and the exact same thing is happening. We're being asked to isolate the close contacts of COVID-positive clients in shelters and drop-ins and respites because isolation spaces were full. We're absolutely not trained for that, and we're doing our best a year into this pandemic to do new IPAC procedures and protocols every day. We're barely staffed and resourced to provide homelessness services as it was beforehand. You know, you have a group of frontline workers who are dealing front lines with the housing crisis and lack of mental health supports. And then before the pandemic, we're dealing the front lines of the opioid crisis. We turned into pseudo-paramedics. And for the past year, we've been pseudo-medical staff, and now we're trying to create isolation spaces. And the way it works on the front lines in our shelter system is the city runs a couple, but the most of these sites are run by different agencies that the city hires out, sort of it's sort of almost a privatization of homelessness services. There's a lot of good agencies involved, but there is arm's length. So each site, it can go really differently, and each site relies heavily on what's called agency staff. These are staff that fill in the gaps in the schedules, and they work multiple sites. These are mostly women. These are women of color who work for these agency staff, in my experience. They have to work several sites. There's no economic supports or backup for them. And, we have our security staff at these sites who also have to work multiple sites. They're getting infected. Multiple of my colleagues who do this kind of work or security staff have now been tested positive. The sites that I worked at where we didn't have any positives in the first wave, we are now run rampant with positives. And yes, you will have some of the executive directors of some of these agencies saying, oh, we can run a recovery site. Yeah, my frontline staff can handle that because they're very eager for the city's contract. They cannot handle it. These are some of the agencies that had some of the biggest breakouts in the first wave, and it's happening again now. I just can't imagine on a public health a pandemic of this level that the best thing to do is try to isolate close contacts of positives in already overcrowded, shelter sites or under-resourced sites, asking, frontline staff to monitor their comings and goings. I could already tell you, I know of over a dozen COVID positive people that are my clients that have been coming and going on transit because there's been no appropriate solutions or spaces provided for them. And we're doing our best to inform them in things, but we are not healthcare staff. We're not medical professionals. And this was a post from a colleague of mine online that was just shared. Out of 70 clients, 20 people left on my floor at work, and these folks refused testing. All who were tested came back positive for COVID. They are even allowing relief staff, well, our site is an outbreak. Relief staff jumped from site to site. What a mess. They offered an extra $5 an hour to work with COVID-positive clients at our Yonge Street site that is an outbreak also. Managers are staying home. You can believe that. Hanging the frontliners out to dry. Are we supposed to isolate after being, the people supposed to be isolating after testing? They aren't. And so they're spreading this expletive around. Toronto shelters are now getting hammered. God help everyone. And so I told a lot of my colleagues and the folks that we work with that I would come here today and just share what's happening again a year later on the front lines. And I just also want to say in the 6 years I've been doing this work frontline in our city, it's never gotten better. And I've worked in spots in all of the wards. So I've done 69 Fraser and Liberty Village. I've done the East End out of the colds at St. Aidan's and United. I've worked from one end of the city to the other, and it's just the pandemic has certainly highlighted these gaps, but it's just so wild that we're in a worse spot than we were a year ago, and these same problems are happening. And thank you everybody for taking the time to sort of hear this and what's happening on the front lines in the homelessness sector. I appreciate the time, and just hopefully some of the recommendations and feedback that you're getting from some folks today can be enacted, because
Tommy, I'm just going to ask you to wrap up in a sentence, as
Yep.
You're just at 5.5 minutes.
Yeah, perfect. I am at the end right there. Anyways, thank you, Councillor Cressy, and thank you everybody for your time today.
Thank you very much, Tommy. I'm most grateful that we were able to get you connected. I would not want our board to miss that. Thank you. Let me just open it up. Are there any questions for Tommy? Tommy, seeing none. Tommy, thank you very much for your work.
Thank you so much.
For the deputation. Next, I have on our list Elizabeth Harrison. Do I have Elizabeth connected in the home?
Yes.
Great. And Elizabeth, I understand that a colleague of yours, Megan Lowry, is not able to be here today, who's registered to speak, but that as part of your deputation, you will be incorporating remarks from her and speaking for both. Is that correct?
We've sort of prepared two deputations together. I was wondering if I could read them both.
Certainly. So you'll have up to 10 minutes there for the two deputations, Elizabeth. And for those keeping track, this is for Elizabeth Harrison and Megan Lowry. Elizabeth, when you're ready.
Thank you, Mr. Cressy. Good day, board members, and thank you for this opportunity to speak. My name is Elizabeth. I'm a registered nurse, and I've been working with people who experience homelessness for years. This year, we responded to calls for action by the community and started a program to provide clinical care directly to unsheltered people where they're living in encampments, on transit, sidewalks. We are in it. We have been providing care to homeless clients with COVID since March of 2020, and we've been providing care to people in the encampment since August. And it's on behalf of these people that we serve that we're compelled to speak to you today, because you must know what's happening out there. And then you, board members, must compel Toronto Public Health to get out there so that you can continue to know what's happening. This winter was harsh. It was cold, and many people that we work with suffered from injuries from exposure to cold that will cause them pain and impairment for the rest of their lives. We saw so many freezing cold injuries, more than we ever had in past years. Dried out, frozen, black fingers and feet that will continue the slow process of falling off for months. Gruesome though these cold injuries are, we know that more people die from extreme hot weather than freeze in the winter. And so we are deeply concerned that without actions from the members of this board, more people will die from exposure and COVID this summer. Because of our experience working as nurses for unsheltered homeless clients, we know that many people rely on informal indoor spaces for shelters from temperature extremes, water, toilets, spending the day in the Eaton Center food court, and then night in the 24/7 McDonald's. These informal spaces, which are like private for-profit spaces, have been acting as a de facto social services, a major pillar propping up a catastrophically inadequate emergency shelter system. This is like common knowledge. Ask any frontline worker, ask any McDonald's worker. This is why like nonprofits have budget lines for Tim Hortons cards, which is shameful. But we believe that this year's increase in visible unsheltered homelessness and the increase in freezing cold injuries is a result of the removal of this unsung pillar during COVID restrictions. Perhaps for the first time, we are seeing people rely entirely on public spaces, on public services, and our government's emergency response to COVID and the emergency shelter system. And what we see is that what the government's providing is insufficient to the degree that people's material and circumstances are so miserable as to threaten their life and limb. Homeless people are spending more of their time in public spaces, parks, transit. They're not choosing parks over hotels, as I've seen it spun. Many see shelters and respites as dangerous. People with the physical stamina to do so are living in the parks instead of the respites because it's obvious to them that a respite is not a safe place to be in terms of communicable disease. And it would be obvious to any of you too. And it's the most vulnerable medically complex clients that are left behind in these congregate settings. And instead of the provision of the most basic public health supports, I'm talking the classics, the greatest hits, hand washing, water, ventilation, removing garbage, letting people stay where they are and not spreading them out across the city. Instead of these rudimentary public health responses, we're seeing efforts made to coerce people out of public spaces, benches and transport stations made spitefully inaccessible for people looking to sit down, trespass notices in parks, looming threats of eviction. Board members, I know that this is not news to you. You know the shelter system is beyond capacity. Like Ms. Wong Tam, Mr. Cressy, Mr. Perks, Mr. Layden, you've been working in the city since these respites open. These are not places for people to live. You knew that respites were dangerous, that they were unsanitary. People were crowded way too close together. Strep, lice, influenza were endemic in these spaces. And you knew that not because you were monitoring, but because we told you so. For years, Toronto Public Health has refused to be involved in the inspection and prevention of and control of communicable diseases and basic standards in these spaces. Dr. Davila, I recall a meeting in 2018 when you told us respites were beyond the purview of TPH IPAC because your focus is upstream. That Toronto Public Health would wash their hands of their responsibility to people who rely on the city's public services for the most basic provisions and antecedents of health, shelter from extreme temperatures, sanitation, water, to suggest that this is like beyond their purview is like baffling. I hope that the pandemic has made it clear to all that the health of all Torontonians is interdependent.
Elizabeth, you're just coming up on 5 minutes there. So for this, I'd just ask you to wrap up the first deputation.
Okay, I'm just going to cut right to the recommendations. Main one, Toronto Public Health infection prevention control investigations should be for all places where people are living. Single room occupancy, respites, warming centers, cooling centers. You know, if the inspections can be done in nail salons and restaurants, they should be for everywhere that homeless people are living. That's the takeaway from that one. Thank you.
Thank you, Elizabeth. And I understand you're reading the second deputation on behalf of Megan Lowry.
Yes, thank you. I've also sent both of these in so that you could read them at your leisure in a less truncated version. Okay, Megan Lowry's.
We've started your time when you're ready, Elizabeth.
Okay. There's never been a day, COVID or pre-COVID, when all of our clients have been able to access a shelter space. In addition to the lack of capacity within the system, there's very little mobility afforded to those who rely on it. We've seen the impact of the city's response for our homeless clients. We've seen successes, including the recovery site, implementation of harm reduction supports, and the expansion of the shelter hotel program to create many single-room occupancy shelter spaces. Our clients need permanent affordable housing in their communities. In the interim, these shelter hotels are a welcome addition to the city's emergency shelter offerings. Unlike the respites, the shelter hotels provide a space which at least allow people the opportunity to isolate and significantly reduce their risk of contracting COVID. What we've seen is that in the drop-ins and the encampment, the safe injection sites where we work, is that most people who need this private, physically distant spaces in the shelter hotel cannot access them. Additionally, those spaces which have been created in response to COVID are not being fully utilized and not being accessed equitably. The shelters and respites are exactly the settings that we have been told to avoid in order to reduce our risk of COVID. They're dangerous. People with the physical stamina to do so are living in parks instead of respites to reduce the risk of COVID. Unfortunately, many of those left behind are the most vulnerable and medically complex. The shelter hotels can be supportive and stabilizing from a physical and mental health perspective, way safer in terms of COVID transmission, but there are so many empty shelter hotel rooms in the system right now, hundreds. Some of these rooms are being held because COVID cases within the facility have resulted in the declaration of an outbreak, which halts all new admissions. While well-intentioned, this is counterproductive intervention in a time when many people are being kept in congregate settings with known outbreaks. Many of the hotel rooms are also being we're told, for individuals staying in encampments to allow for the clearing of the encampments. One downtown hotel is staffed and yet approximately half empty, over 100 empty rooms, full empty floors, due to a combination of outbreak and preserving these rooms for encampment clearings. Board members, we must prioritize getting the most at risk of harm to safety, and this means getting those who wish to leave congregate settings the opportunity to move out, especially those who are medically at risk. We know the empty rooms in the shelter we know that there's empty rooms in the shelter hotels, and yet people who are older with many medical complexities cannot leave the congregate shelter where there's a known COVID outbreak, where they're at risk of getting COVID. We call central intake for people we meet on the street, exhausted in crisis. We told there's no space. Unbelievably, in this time when the recovery site is full, the hospitals are all at surge, they're all similarly stuck with individuals who are ready to be discharged from acute care or who have completed their isolation period. They call central intake and told there are no beds. I'm just going to go ahead and skip to the recommendations here, which is to increase the capacity of the emergency shelter system, specifically single room occupancy sites, which promote physical distancing and have ventilation. Toronto Public Health, increase IPAC support to all emergency shelter programs, and to account for the differences between shelter hotel, and respite centers, which are all being managed the same right now. Tailor IPAC recommendations specifically to the outbreak management of each program with the goal of safely preserving the shelter space, and then and continue to support them. Pathway for hospital discharge planners and workers to have expedited access to these shelter hotel spaces. In the context of a surge of COVID cases, individuals must be discharged to street where there are no beds available intake. We see every day how people are at risk of losing whatever gains they made in terms of their health and stabilization when they're discharged to street. And then transparent, accessible, timely communication with people who utilize emergency systems related to the case counts and outbreaks with as much detail as possible while maintaining confidentiality. As far as everyone knows, when there's an outbreak—
So just a heads up, you're just coming up on 5 minutes for Megan's deputation, if you could seek to wrap up.
Okay. Yeah, I think I can wrap up there. Just that, right now the shelter system's beyond capacity, yet still there are hundreds of empty rooms. And I think that this is because of like a lack of Toronto Public Health like involvement and support in IPAC in these spaces and tailored.
I'm gonna, Elizabeth, just because we're coming up on 6 minutes there.
Thank you.
Thank you.
Thank you so much.
Thank you very much for that, Elizabeth, and as well on behalf of Megan Lowry. Can I open it up? Are there any questions for Elizabeth? I have a question from Councillor Ainsley when you're ready.
Thank you, Chair Cressy. So Elizabeth, just so you're saying from your practical experience, people are being released with health conditions. They're being released back onto the street. They're expected to go back to a congregate setting or a respite center or a shelter. And they're being told they're full. And you know for a fact that hotel rooms are going empty.
Yes.
Okay, so
I've
sorry,
also
go ahead.
But yeah, I've had the situation where because there's no sort of, we've created these spaces that are so much more supportive, that are so much safer, but there's no way for the people who need them most to access them. I've had situations where we have clients who have like significant frostbite, who go to the hospital, do their whole hospital thing, are admitted, but then when they're discharged, they call, they say there's no room. The whole esplanade is empty, but it's being held for people who are in encampments. So this client is discharged back to street and has to go back with their frozen feet and shuffle around in the snow until I can find them, connect with them, and then connect with them with the Streets to Home encampment support and get them in that way. And wouldn't it have been great for that person and their feet if they didn't have to shuffle around in the snow for another afternoon, like if there was a direct line of like a referral pathway from hospital discharge planners from the recovery site to these places with more supports, more stability, or if people who were the most vulnerable could leave from these respite situations and get there.
Yeah, and I guess from what you're trying to, and I guess what I'd also ask Elizabeth, so you're talking, and the example that you just gave about a person that has frostbite on their feet, they're going back to an encampment because they can't find a room in a shelter. There's beds in the hotels set aside for people who are trying to get out of encampments, but they're leaving a hospital and they're going right back to an encampment, which is what we're trying to avoid in the first place.
Yes.
Okay.
Yeah.
And then I guess I'd also ask from your experience, we're trying to get people out of the encampments into hotel rooms because we're told that those are the best place for them to be. But I'm also being told that people don't like to be in the hotel rooms. They would rather be in an encampment.
So I guess it's that from what we've seen, it's the people who we mentioned who have like the most physical stamina, who are like the most organized, most engaged. They're able to live in the encampments and like build communities there. The people who are, very at risk, who are very complex, are the people who cannot manage that and who are sort of stuck in respite or possibly just kind of shuffling around on the TTC endlessly.
Okay. All right. And so I guess what you would like to see the city doing is looking at our shelter system now and seeing, what we can do to get it operating properly without the silos post-COVID, correct?
Well, I see that there's this like real choke point around admissions to some of these shelter hotels, that they're being held empty specifically for people from encampments, and yet the recovery site is not able to discharge people because there's no space, and yet the hospitals are not able to discharge people because there's no space, and yet there is a ton of space. it's just being held for people from the encampments who don't want it.
Who you're trying to get out of the encampments into the hotels.
Yeah, I think also just having just in addition to the centralized system, opening it up so that there is some pathway between hospital discharge planners, hospital social workers, and or even emerge social workers to have some sort of anything else other than calling central intake, have some sort of just allow them to make partnerships with the operators of these shelter hotels. I think that if people could be discharged from hospital to those shelter hotels or from recovery site to the shelter hotels, there'd be a lot less misery in the world. I also think especially in the context of the recovery site where people have just completed COVID, they had COVID, they've completed COVID, they've been medically cleared, and the fact that there's nowhere to discharge them to because places are on outbreak, it just seems just baffling. Anyway, there could be a lot of solutions. 100 empty beds in a hotel downtown, not ideal.
Councillor, we're just over 5 minutes there.
Yep.
So
Thank you, Chair Cressy. Those are my questions. Thank you.
Just seeing, are there any other questions for Elizabeth? Okay, thank you. Thank you very much, Elizabeth. Our next speaker is Abigail Doris from the Toronto Community for Better Childcare. Do we have Abigail on the line?
Hello, this is Abigail speaking.
Oh, hi, Abigail. When you're ready, you'll have 5 minutes.
Thank you. Good morning, everyone. Thank you for the opportunity to speak today. As mentioned, my name is Abigail Doris. I'm a registered early childhood educator, and I'm also the executive coordinator for the Toronto Community for Better Childcare. Toronto City Council, the Mayor, Toronto Public Health, and the Board of Health have all heard from nonprofit childcare centers this past week, pleading for vaccinations for their frontline staff. The childcare workforce is exhausted, and they are actively getting sick. In the past few weeks, we've seen a rapid rise in COVID cases in our childcare centers, driven primarily by the more contagious variants of the virus. As reported last week, you likely heard on City TV, we're experiencing a surge in cases among young children. In the past 2 weeks, there have been more than 500 reported cases in childcare centers across Ontario. This includes here in Toronto. That's nearly 25% of the total cases reported in childcare centers since the start of the pandemic. And despite diligent efforts by our frontline staff, these more contagious variants are being spread in childcare centers from child to child and to staff. ECEs and childcare workers are in regular direct contact with young children, many of whom can't wear masks and don't yet have the understanding of what physical distancing is. The youngest in our classrooms require direct support with eating, diapering, and toileting. And counselors, as many of you have young children of your own, you can understand the direct contact and support that young children require. As leaders in our province, we look to the City of Toronto and our local public health unit to take immediate action that is proactive and solutions-based and centralizes community care. In vaccinating childcare workers, you are protecting not only the workforce, but the children and families that we work with. And it's possible. We're seeing public health units in other regions of Ontario refocus their vaccination strategy. For example, the Niagara region has confirmed that they will be vaccinating all of their frontline educators, including early childhood educators and childcare workers this week. In York region, they are simultaneously vaccinating frontline workers while rolling out the province's phase 2 plan. Halton region has confirmed they are starting vaccinations for all childcare staff alongside teachers starting this Friday. Other regions have created centralized wait lists for education and childcare workers to be on call for end-of-day doses, including Durham and the Kawarthas region. I'm here today asking you to join these other regions in their community-based approaches and prioritize childcare workers. We have a window of opportunity while schools are closed to use these spaces as vaccination pop-ups in conjunction with mobile clinics and workplace pilots. There are 433 childcare centers located in schools in Toronto, serving all age groups. These centers could also serve as vaccination hubs for the more than 600 childcare centers located in surrounding neighborhoods who are not currently prioritized by the province to be receiving vaccines alongside teachers. It is inequitable and unjust for the province not to include childcare workers in its vaccine prioritization with teachers. We continue to hear from decision makers at all levels of government how essential childcare is to our economy, and that it is critical that childcare centers remain open to serve our communities. And we have. Through lockdowns and school closures, the childcare community has continued to provide high quality care throughout Toronto. But supporting the economy can't come at the cost of the well-being of ECEs and childcare workers. It is entirely inequitable that we continue to see provincial public policy that undervalues and jeopardizes the lives of feminized, racialized care workers. Your leadership is critical. The province has largely ignored the recommendations of the Ontario Coalition for Better Childcare and the Association of Early Childhood Educators of Ontario. This includes pandemic pay, paid sick leave, and smaller cohort sizes in our classrooms. We as a sector are doing our very best to protect your children and each other, and it shouldn't cost us our lives. Throughout the pandemic, the province has continued to neglect the childcare sector. We need the city to advocate for us because the province simply isn't. I want to thank you for your time today. Toronto's 1,051 childcare centers and the 80,000 children we provide care for look forward to seeing you take bold and immediate action regarding a progressive and effective vaccination strategy that includes early childhood educators and childcare workers in Toronto. Thank you.
Thank you, Abigail. Let me open it up now. Are there questions from members of the board? Abigail, just one from me, and it's a question I'll pose to Dr. Davila later, but so the provincial government announced last week that educators, which includes teachers, but also those working in those schools, will be eligible to register for vaccines who work in or live in hard-hit neighborhoods in the city of Toronto. So is it your understanding that early childhood educators and essential childcare workers were not included?
Yes, that's correct. During the announcement that was made by the province, it was noted that childcare workers are excluded. The province then went back to make another announcement to say that ECEs would be included if they work in a school building and work directly with school-age children. Well, in the 433 centers that we have located in schools, they work with all age groups. It's unequitable to have some folks, and we use shared spaces in our school age programs in schools. So we are in the exact same classrooms as teachers are during the day. It's unequitable to not recognize how risky the work is for childcare workers, especially those who work with younger age groups who aren't masked and need closer contact and closer support.
Thank you for that, Abigail. Our next speaker is Carolyn Ferns from the Ontario Coalition for Better Childcare in the Home. Do we have Carolyn connected on the line?
Hello, I'm here. Can you hear me?
We can hear you, Carolyn. When you're ready, you'll have 5 minutes.
Great. Thank you, Councillor Cressy. My name is Carolyn Ferns, and I'm the Public Policy Coordinator at the Ontario Coalition for Better Childcare. Thank you so much for the opportunity to speak today to the need to vaccinate early childhood educators and childcare workers in licensed childcare programs as soon as possible. As Abigail mentioned, last week we saw an announcement from the Ministry of Education that there would be targeted vaccination of teachers and education workers in schools in hotspot areas. Then that would include early childhood educators in schools who work with school-age children. It would exclude early childhood educators and childcare workers in licensed childcare in schools working with younger age groups, as well as all early childhood educators and childcare workers in community-based childcare centers. The province also announced vaccination of special education teachers and workers across the province. And that's an excellent initiative, but there is a conspicuous omission of early childhood educators and childcare workers in licensed childcare programs, despite the fact that the majority of childcare centers are in schools And this is despite the fact that childcare workers face the same risks as other education workers. Their risks are most similar to those of special education workers, and sometimes the risks, I would argue, are even greater. Early childhood educators and childcare workers in licensed childcare do close, caring work with unmasked children who do not yet know how to physically distance. As Abigail mentioned, they're involved in toileting, diapering, comforting a crying toddler, playing with a preschooler who might pull off your face shield, a toddler who might sneeze right in your face. You get the idea. And we're asking childcare workers to stay open, even now, even as schools are closed. And we ask early childhood educators and childcare workers to provide emergency childcare to essential workers. But we don't respect them for their essential work, and we don't do all we can to protect them in an emergency. We ask childcare workers to stay open to support the economy, but our province does not support them. And we ask early childhood educators and childcare workers to do the impossible, and they do it. They choke back their tears, they put on a smile, they give the province's young children the best care they can. Happy, rich education and care experiences in the middle of a pandemic. The very least we can do for childcare workers is to give them a shot in the arm now. Let's ensure that we vaccinate ECEs and childcare workers as soon as possible. Thank you very much.
Thank you very much, Carolyn. Let me open up the floor. Are there any questions for Carolyn? Well, maybe just one on my end. Carolyn, is the request of Toronto Public Health is, just to be clear, is it for us to do whatever is in our control, be it advocacy or otherwise, to see that early childhood educators and childcare workers are considered just like educators who, in the broader school system, who have access to vaccines?
Yes, absolutely, Councillor Cressy. Within the City of Toronto, anything that can be done to make sure that early childhood educators and childcare workers in licensed childcare are prioritized in the same way. If there's targeted outreach going on to vaccinate workers in schools, include licensed childcare, include licensed childcare centers in the community. But your leadership and advocacy is also needed to the provincial government. When they first announced, the phase, who would be prioritized in phase 2, childcare workers were absent from the list, where teachers and educators were. We advocated to them to have them included there, but now when time comes out for it to roll out, we're again seeing them forgotten. So it seems to be a chronic problem, and so anything you can do to raise the issue to the province would be very helpful. Thank you so much.
Thank you very much, Carolyn. Our next speaker is Derek Moran. Do we have Derek connected on the line?
Can you guys hear me?
We can, Derek. You know the drill. You'll have 5 minutes when you're ready.
Okay, I'm just going to start my clock here. I just want to say, by me speaking at this meeting, this shall not be deemed to be in any way the consent expressed or implied, in doing so is fraud. God bless Her Majesty the Queen, and long live Her Majesty the Queen. As I've heard Dr. Davila say numerous times that her decisions are based partly on the scientific literature, I wanted to share with all of you something I came across from the NCBI, National Center for Biotechnology Information, from a cardiologist with ties to Stanford University, Baruch Vain-Shelbaum, who wrote a wide-ranging article on the response to COVID-19, and I provide the link to it in my written presentation. With respect to mental health, global estimates showing that COVID-19 will cause a catastrophe due to collateral psychological damage such as quarantine, lockdowns, unemployment, economic collapse, social isolation, violence, and suicides. Chronic stress, along with hypoxic and hypercapnic conditions, knocks the body out of balance and can cause headaches, fatigue, stomach issues, muscle tension, mood disturbances, insomnia, and accelerated aging. This state suppressing the immune system to protect the body from viruses and bacteria, decreasing cognitive function, promoting the developing and exacerbating the major health issues including hypertension, cardiovascular disease, diabetes, cancer, Alzheimer's disease, rising anxiety and depression states, causes isolation and loneliness, and increasing the risk for premature mortality. given the fact that asymptomatic or minimally symptomatic cases is several times higher than the number of reported cases. The case fatality rate is considerably less than 1%. This was confirmed by the head of the National Institute of Allergy and Infectious Diseases from the U.S., stating, "The overall clinical consequences of COVID-19 are similar to those of severe seasonal influenza, having a case fatality rate of approximately 0.1%. In addition, data from hospitalized patients with COVID-19 and general public indicate that the majority of deaths were among older and chronically ill individuals, supporting the possibility that the virus may exacerbate existing conditions, but rarely causes death by itself. In addition to hypoxia and hypercapnia, breathing through face mask residues bacterial and germs components on the inner and outer layer of the face mask. These toxic components are repeatedly rebreathed back into the body, causing self-contamination. Breathing through face masks also increases temperature and humidity in the space between the mouth and the mask, resulting in a release of toxic particles from the mask's materials. A systematic literature review estimated that aerosol contamination levels of face masks, including 13 to 202,549 different viruses. Rebreathing contaminated air with high bacterial and toxic particle concentrations, along with low O2 and high CO2 levels, continuously challenge the body homeostasis, causing self-toxicity and immunosuppression. Respiratory protection standards from Occupational Health and Health Administration of U.S. Department of Labor states that breathing air with O2 concentration below 19.5% is considered oxygen deficiency, causing physiological and health adverse effects. These include increased breathing frequency, accelerated heart rate, and cognitive impairments related to thinking and coordination. A chronic state of mild hypoxia and hypercapnia has been shown as primarily mechanism for developing cognitive dysfunction based on animal studies and studies in patients with chronic obstructive pulmonary disease. The existing scientific evidence has challenged the safety and efficacy of wearing face masks as preventative intervention for COVID-19. The data suggests that both medical and non-medical face masks are ineffective to block human-to-human transmission of viral and infectious disease such as SARS-CoV-2 and COVID-19, supporting against the usage of face masks. Wearing face masks has been demonstrated to have substantial adverse physiological and psychological effects. And I'll end by saying, I just want to point out to you, Councillor Cressy, when you asked Dr. DeVilla for the evidence supporting a recommendation for mandatory mask wearing at Council last June, she evaded your question and never actually gave any, and now you know why.
Thank you for your deputation, Derek. Let me open it up to members of the board. Are there questions for Derek? Okay, seeing none, our final deputant here today is Roxy Danielson from the Street Nurses Network. Roxy, do we have you connected on the line?
Hi there, can you hear me?
We can hear you, Roxy. Welcome to the board. Thank you for being here. You'll have 5 minutes when you're ready.
Great, thank you, Councillor Cressy, Dr. DeVilla, and Board of Health members. And thank you to my fellow nurses and frontline workers who've taken the time to speak today. I'm Roxy Danielson, and I've been working as a street nurse right here in downtown Toronto for the past 7 years, including still working full-time on the front lines during the pandemic. In fact, I'm at work right now. As a street nurse who works primarily with people who are homeless, I'm here to ask for immediate action on prioritizing the safety of all people experiencing homelessness within the shelter system and in encampments. As we know, public health measures to stop the spread of COVID-19 include having your own space to physically distance, wearing proper PPE, including N95 masks, practicing infection control, and getting the COVID-19 vaccine when available. Since the start of the pandemic, folks who are homeless were not given adequate support to enforce these critical public health measures, despite many frontline workers and homeless people speaking out. There has been difficult access to safe shelter beds, as Elizabeth was discussing, limited access to masks, and now a slow vaccine rollout. With over 300 COVID-19 cases within the shelter system, things have gotten out of control. For people who reside in shelters, the current practices make it impossible for anyone to avoid getting COVID-19, as we have seen with several shelters currently on outbreak status and with a designated recovery hotel at or near capacity. Some shelter users have been asked to isolate in place, forcing those who have COVID-19 to live among those who don't, increasing the needless risk of spreading the disease. Without means to properly isolate, there's no way to protect shelter users from becoming exposed to COVID-19. Given the increased risk of getting COVID-19 within the shelter system, many people have taken to living in encampments. Many homeless folks have expressed that they feel safer outside than in a congregate setting where the risk of getting the disease is real. Despite homeless people trying to live in a way that is safe for them, the city has issued trespass notices to encampment residents and has been forcing them off parks and into shelters that are already full and potentially overrun with COVID-19. As a nurse, I know how dangerous getting COVID-19 can be, especially for people experiencing homelessness. I think by this point, we have all seen or heard of this study by the Institute for Clinical Evaluative Sciences, which shows that homeless people are 20 times more likely to be hospitalized, 10 times more likely to be admitted to the ICU, and 5 times more likely to die from COVID-19. Given that we're in the third wave of the pandemic with COVID-19 cases still on the rise and ICUs being more overwhelmed than ever, we need to do everything in our power to protect people from getting the disease. The city needs to retract the trespass notices and put a moratorium on encampment evictions, all while looking for more recovery hotels for people to safely isolate, as well as implement single-room shelters to prevent the spread. The city also needs to ensure every homeless person and shelter worker has timely access to the COVID-19 vaccine and proper PPE, including N95 masks. People deserve safe places to live with access to proper measures to help avoid getting COVID-19. It is vital that we do all we can to protect the lives of homeless people before this dire situation becomes worse. Thank you.
Thank you very much, Roxy. Let me open up the floor. Are there any questions for Roxy? Okay, seeing none. That now takes us to the end of our registered speakers, so thank you all. We're now going to move this into committee for questions of staff. I would just note for members of the board, for your benefit, of course, we have staff here from Toronto Public Health, but if there are questions for other city divisions, we do have staff here from Social Development and Finance Administration, who oversee the Equity Action Plan and the Vaccine Mobilization Plan, as well as staff here from Shelter Support and Housing Administration, overseeing work supporting those experiencing homelessness. Let me start a speakers list here. And again, I can't see everybody on one screen. So, okay, I see Trustee Donaldson, Director Mulligan, Councillor Layton, Councillor Ainsley, Councillor Perks. Okay, I'm just casting around. I'm shifting screens here. Okay, we will begin. I'll begin with that running order. We have 5 on the list, and if there are others, so Trustee Donaldson, when you are ready.
Thanks, through you, Chair. Thanks, Dr. Davila, for your presentation and for everything, as always. My questions this morning are focused on schools for today and vaccinations for education workers. So I'll start with the Section 22 order and ask about jurisdiction. So does the province have the power to close school boards themselves, individual school boards, and they're just not using it?
So through the chair, I believe the province certainly has powers that expand or that are greater than ours. I do believe that they can do that. In fact, if you look back at that which happened earlier this year in Wave 2, schools were reopened in regional format. So you can see that they can tailor their powers.
Okay. Now that we do have a Section 22 in Toronto, and it goes until the end of this break, then we're in a position now likely where we will based on the numbers that you just showed us, and I know you said, given the data, there will be decision to extend. We're in the territory of continuing with the Section 22. Is that correct?
So through the chair, certainly the numbers are concerning, but I would also point out for members of the board that looking at community transmission around the province, it's not just Toronto clearly that has very high community transmission, and therefore there is an active conversation around the province around what should be done, both in terms of broader community public health measures and as well in consideration of schools. Okay.
And in terms of a notice period for families about an extended closure, how early could families be notified that this is going to happen? And I know the data is changing day to day, but what could be done, do you think?
So through the chair, what we would really like to do is offer families as early notice as possible. It's never our intention to, leave families scrambling, unless there is, a significant health risk or an issue for which we feel that that's necessary. So our sincere hope is that, in speaking to the team, to my mind, Thursday at the latest is really something, given that, school is meant to start on Monday, people do need to have some time to plan. In order to make the necessary arrangements. So certainly that's very much top of mind for us.
Thank you. I really appreciate hearing you say that. So this morning we're hearing that teachers who are work with special education staff who had priority have been calling the provincial portal, and they're getting bookings late April and into May. So I just wanted to make sure that you're aware of that, because I imagine, because of what you said about the fact that there are supply issues that perhaps are entering into the reason for that. And so I have questions about the process to book for special education workers, for teachers in hotspots, and the process to book for education workers overall. So is there guidance that you can provide right now publicly about what the process to book is for education workers who work with special education students?
So through the chair, yes, and it's actually relatively simple for Toronto. So whether we're talking about those who work within the realm of special education or education workers who live or work in hotspots in Toronto, what we have been advised by our provincial partners is that these individuals can call the provincial call center, let them know that they are a special education worker or an education worker writ large, and book an appointment for vaccine through that provincial call center. So what that provincial call center allows for is booking into any immunization clinic that is on the provincial booking system. And that includes all of the mass immunization clinics run by the City of Toronto, Toronto Public Health.
Okay, thanks. And then in terms of if you're not an education worker who works with special education students, and if you're not in a hotspot, what is the status for those education workers right now?
So through the chair, at this point in time, the focus is on those special education workers and those in the hotspots. We have yet to hear from our provincial counterparts about the next steps. Again, these are all announcements, as you know, that were just provided for in the last few days. So we've got to the first point where we know what the plan is for special education and for education workers who live or work in hotspots. I anticipate that we'll hear more from the province on the next steps. There is an issue, though, as I provided in the presentation, throughout the City of Toronto, whether you're talking about City of Toronto, Toronto Public Health Clinics, or those offered by our healthcare partners. We have plenty of capacity. In fact, we are not operating at full-on capacity, and that's because we actually do have a challenge currently in respect of vaccine supply.
Thanks. I see that my time is well over, so I'll leave it there. Thanks very much.
Thank you.
Thank you, Trustee Donaldson. And I noted Director Bowery and Councillor Wong-Tam, I've added you to the list. I got your texts. Thank you. Next up, I have Director Mulligan. Director, when you're ready.
Thank you very much, Mr. Chair, and thank you, Dr. Davila. I have a question about the provincial prioritization framework. To what extent is this framework binding, and do you have powers to act outside the prioritization framework to prioritize different people?
So through the chair, I wouldn't say that it's necessarily binding, but certainly from a provincial perspective, we are all being asked to adhere to the greatest extent possible to it in order to facilitate, I think simplicity of communication so that there's less confusion created in the system. And as you can see, we have altered, on occasion from the provincial framework, but in keeping with the notion of risk. So for example, we brought up shelters into phase 1 of the vaccination prioritization framework for us here in Toronto. And we're continuing to make adjustments on an as needed basis. But of course, we do communicate with our provincial counterparts.
Thank you. So were there conversations then about changing prioritization for those hotspot communities, for example, earlier on? Since we've known for over a year and well before that what the maps were going to look like, and that the maps of vaccination rates and the maps of risk are so similar. Why are we waiting for the province prioritization framework to get us there?
So through the chair, I don't think it's that we're waiting for the province's prioritization framework. That certainly makes it easier to manage, risks for sure around the province. But I would say this, when it comes to our own immunization clinics, you may recall that we are clients of the provincial booking system. So the manner in which we can actually populate our vaccine clinics is restricted by the terms that are built into the provincial booking system, which has until very recently focused on age bands. So we've been getting at risk populations and risk neighborhoods, largely through our other partners who are not constrained in quite the same way by the parameters of the provincial booking system. We have some healthcare partners who are on the provincial booking system and are similarly constrained, others who are not, and they are actively going out to different neighborhoods and have been for quite some time now.
So Dr. Davila, do you recommend then that we as a board ask for changes to that booking system?
So through the chair, we have already been making those asks, and in fact, those are being reflected now.
Okay, thank you very much. I want to ask about the vaccine supply. Why do we have low supply right now in Toronto?
So through the chair, that's probably a question better directed towards the province. We receive vaccine from the province as per, all vaccines that they're ordered at the federal level. Procurement happens federally. Distribution then happens at the to the provinces, and the provinces then provide vaccines to the local public health units and jurisdictions. So we are managing with the supply that we have. But clearly, I have made requests and would suggest that further requests are needed for more vaccine in order to address our particular circumstances here in Toronto.
Thank you very much. And my last question for the moment is around, the increasing seriousness of this wave and the transmissibility of the variants. Do you have changed advice for people? We heard a lot of fear, for me, maybe for the first time by the deputants today around what they need to be doing with respect to infection control, protecting themselves, protecting others, maybe moving to N95 masks. But I'm not, to my ears, I haven't heard significant change in the risk communication that's going out to people. What do Torontonians need to know in terms of changing their behaviors or knowing what's different about this wave compared to earlier waves of the pandemic?
So through the chair, I would say this, that we know that distance makes the difference. So the more that people can actually stay home and limit their interactions to the greatest extent possible, that is first and foremost the first line of defense. We recognize that people do need to go out and about. In those circumstances, it's, wear a mask as much as you can, and of course, maintain distance to the greatest extent possible. I think the other component here, and perhaps this is, both blessing and curse, is that we have vaccine available to us this time around relative to previous waves. But vaccine isn't about the now. It's about the future. It does take a few weeks before we actually feel the full impact of vaccine, but we have seen the benefits of vaccine within our long-term care homes and retirement homes. That's the kind of benefit we wish to be able to confer across the entire population for the City of Toronto. But it does require supply. And of course, it has to be administered to people over time with particular focus on those in the highest risk circumstances. And so to my mind, it's distance as much as possible for now. And when your turn for vaccine comes up, please take advantage of that opportunity.
Thank you, Director Mulligan. Next up, I have Councillor Layton.
Thank you very much. I've got a couple questions about vaccine rollout and then a couple about homelessness and shelters. So first on the determination of the postal code prefixes are in the news today, not for a good reason. But I just wanted to, could you give us some insight into how and why the postal code prefixes were used and why not a finer grained, more targeted approach? Because we've got some communities that have high numbers, but they don't exist in a postal code prefix, I suspect because on average that prefix may have a considerably lower number. But can you talk us through what the sort of methodology was for using those prefixes?
So through the chair, Councillor, I'll do the best I can because the determination of those hotspots was done by the province. So it's obviously more complicated for me to speak to the provincial work. My understanding is that they used cumulative incidents. They looked at COVID-19 incidents in communities and then premised the hotspot data on that. I can assure you though that while we of course pay attention to that because it's necessary for us to focus on that, given that we're clients of the provincial booking system, and those are the defining characteristics of how hotspots are determined within that booking system. We are continuing to do our own work to make sure that we are truly focusing efforts that are happening on the ground here on all the areas where we know we have high incidence of disease, hospitalizations, deaths, and of course, in concert with data that we have on income, racialization, and overcrowded housing.
Thank you very much. The next question to our shelter support and housing staff who's on the call.
Hello, Councillor. It's Marianne.
Hi, Marianne. Thank you so much for being here and to ask questions today. You heard the couple of speakers here, and most of my questions I think are going to be in line with some clarification points from city staff along those lines. One on the calling in of the Red Cross or the medical side of the armed forces. Where are we in the possibility of doing that?
We have had some conversations with the Red Cross, but in terms of that, it would be helping us with our vaccine rollout. Up till now, we've been working really closely with all of our healthcare partners that do provide healthcare to people experiencing homelessness. And they have not indicated that, any emergency medical assistance is needed at this time, but just a lot of coordination right across the system.
So every summer we face this question about what is a warm weather response to address the needs of those experiencing homelessness and keeping everyone safe. Has the city done its planning to meet the need this year, which it will no doubt be greater than last year as we continue to trend towards higher numbers. Have you done any preliminary planning that you can share now?
We work very closely with Toronto Public Health that is responsible for the rollout of the summer's heat relief program. A couple of years ago, there was a large sort of overhaul of the program, making more community spaces available. We do know that there is difficulty with COVID-19 and a lot of those spaces being unavailable, but we have been working very closely with all of our shelter operators to make sure that as much as we can, air conditioning in the shelters are available. What we focus on in community spaces are people who are not sheltered, who need relief from the heat, but we're very much in those active conversations with public health.
So water and hand washing in public spaces, and particularly in parks with encampments, are we making steps to turn that water back on? Like we shut it off during the winter. Are we taking steps to start getting that moving now, getting hand washing stations back out? Because we know that that's the continued advice from the medical officer of health, and keeping higher sanitary conditions in encampments, albeit is a difficult task. It's certainly one that we might be able to contribute to. Are we making any steps along towards that end?
Well, we are working very closely with Parks, Forestry and Recreation to get water turned back on. There are some challenges with drinking fountains and required public health protocols around cleaning, but we are, working to find solutions to those issues. We're also making sure that water during the warm weather especially is distributed through our Streets to Homes staff and our partner agencies who are in each of the encampments right across the city.
If I could just add one recommendation to that, is that ice also be added to that list. I know in my conversations with individuals that was something that the city could help with in order to address the issues of heat in the summer. Just on one last question, because it came up in the deputations on the holdback of rooms. Can you give us a snapshot as to how many rooms are out there, what's being held back in the shelter hotels as a result of outbreaks, as a result of sort of targeted groups that were going to be, that those rooms were to be dedicated towards, and why?
So, Councillor, as the deputants mentioned, we do have
Councillor, that was your last question as you're over 6.
We do have a number of active outbreaks in the shelter system. When a program is in active outbreak, we're not able to take any new referrals into that program. So currently we have about 300 beds that are offline until the shelter outbreak has resolved. I think one of the programs that the deputant was referring to was a shelter hotel program that we opened in the downtown, very specifically for a pilot project to bring people inside from encampments. So the majority of those rooms have been dedicated for use by people in these 4 prioritized encampments. They are being held for people in encampments. What we don't want to do is create a program, spend some very dedicated time working with people, and then when it comes time for them to be able to come inside, the space has gone. But we have been providing access to that location for people with prioritized health needs. And probably about half of the rooms that are currently being used in that program are being used by people that have been referred from other encampments.
Thank you very much. Our next to ask questions is Councillor Ainsley. Councillor, when you're ready.
Thank you, Chair Cressy. I did want to ask about the city's website when it comes to COVID-19. If it was possible to have a specific tab for information for businesses and for people to understand the COVID-19 practices or procedures that have to be in place for businesses. Our website's not very clear. There is a link that sends us to the provincial guidelines, but I regularly get questions from residents about, they went into a store and there's no plastic shield across the counter. The staff are wearing masks. I'm just wondering if we could have a specific tab with that information on the city website for it's easier for businesses and individuals to find.
So through the chair, I'll raise that with the relevant communications folks to see what we can do about making that easier to find.
Okay, thank you. And then I wanted to ask about the mobile vaccination clinics, or the pop-up vaccination clinics, how they get advertised to a specific building or neighborhood. I have I have 5 neighborhood improvement areas in my ward. Some people with not a lot of computer access, so I do get regular questions about how they figure out where the mobile vaccination centers are going to be and when they're coming.
So through the chair, Councillor, the way most of the mobile or pop-up clinics have been operating, they've largely been done by our healthcare partners and Ontario Health teams in concert with community agencies. And traditionally, what they have done is done some on-the-ground advertising, particularly for buildings or communities where they're trying to focus their efforts. So it tends not to be a very broad scale kind of advertising, because they are meant to be focused vaccination initiatives for certain populations or communities, and in some cases, certain buildings. So that's why the advertising has been very focused and specific for those endeavors. They're concerned that they want to make sure that they've got vaccine, and that the people who are attending are in fact those that they are seeking to focus those vaccination efforts on.
Okay, so for example, for an apartment building, it would be a hard copy flyer drop in mailboxes?
For example.
Okay, perfect. And then in terms of hotspots for people that are under the age of 50, I know Dr. Davila, you did say that we are working on our vaccine supply, and it's the federal government, and there's a whole raft of issues there. But do we have any idea of when we would begin vaccinating people in hotspots under the age of 50?
So through the chair, that the opportunity to book for those under 50 in hotspots started on Friday, if I've got my days right. First thing Friday morning.
So they would go through the vaccine TO website, or is that?
Yes, they can. Yes, and or through the provincial call center. So it is available on the provincial booking system. That's correct.
Okay. And then the other concern I have when it comes to teachers is teachers, for example, that work at a school in Scarborough, but live in another region, and they're very concerned that they're going to be coming into Scarborough but not being vaccinated, and how they deal with that, or that would be the province again.
So through the chair, the provincial government has indicated that for education workers, those who either live or work in hotspots are actually eligible to receive vaccine. And the hotspots, we're talking about hotspots right now in Peel and in Toronto. So that's the extent to which they have covered this. And again, it's live or work, and it's those hotspots designated by the first 3 digits of postal code that the province has provided.
Okay, thank you. And then my last question, I believe Marianne Bedard is still on the line.
I am, Councillor.
Marianne, I just wanted to follow up on Councillor Layton's question about providing hand washing stations in encampments, and I guess hand sanitizer. But we know where the outdoor encampments are. Do we provide portable toilets?
We do, Councillor. Working with Parks, Forest and Recreation, we did provide portable washrooms in many of the parks, both for use of local residents who are using the parks and also people who were staying outside.
Okay, so they're readily available to the encampments.
They are in a number of spaces. We weren't able to continue with the hand washing stations because of the temperatures, but we will work with PFNR to make sure that those are available again this summer.
Okay, all right, thank you very much. Those are my questions, Chair Cressy. Thank you.
Certainly, and Dr. Davila, I understand you just wanted a point of clarification. Yes. There.
And with thanks to my staff, and in particular to Dr. Lamptey, Councillor Ainsley, with my apologies, I realized I must be suffering from an overworked brain. What I should have
I can only imagine.
So I do apologize for that. My brain has clearly mixed things up, and I do apologize. So for hotspots, 50 years of age and older is what opened up on the provincial system. So I do apologize. So let me be very, very clear. With the recent provincial announcements, when it comes to hotspots, those 50 years of age and older can now book through the provincial system. They can also book through some of our hospital partners and healthcare partners, individual booking sites as well. So it's 50 plus that can be seen through the broad range of clinics. When it comes to those 18 plus, I got focused on 15 and I was 50, I should say. When it comes to those younger than 50 years of age who are residents of hotspot neighborhoods as identified by those forward sortation areas delineated by the province, those individuals right now are available to partake in vaccine clinics in their communities that are mobile or pop-up. I realize that's very confusing, but that is the current state of affairs. And as you can see, even I get confused from time to time. I do apologize for that.
Well, that's okay. I'm sure, you know, everything that you have to deal with every day. I can't thank you enough for all the work you do and your staff as well. Thank you very much.
Yes, and thank you to my staff for pointing that out to me. I do appreciate it.
Thank you. Thank you, Chair Cressy.
Okay. Next, we have Councillor Perks.
Thank you. Dr. Davila, so the province announced that teachers in those postal codes, teachers in Toronto, can get vaccinated through the various city and partner agency vaccination sites, right?
That's correct.
And did the province increase the supply of vaccine to the city of Toronto to cover that population?
So, you know, the province has provided for teachers to be able to get vaccine in hotspot, those who live and work in hotspot areas. We have not received additional vaccine for that.
About how many people is that? The education workers?
So we are working with our education partners, but we believe when we take special education workers and the relevant education workers who qualify, roughly 40,000-ish, probably more.
Okay. And for the mobile pop-ups in areas of concern or hotspot areas to 18 and over, the province has announced that people can get vaccinated in that group, right?
That is correct.
And did the province increase the supply of vaccine to the city of Toronto to cover that group?
There was no specific additional vaccine provided for that.
And just roughly, and I know it's difficult to do, could you give me a ballpark estimate of how many people that is?
You know, I'm sorry, through the chair, I'm afraid I don't have that, Councillor Perks, but I'm sure I can get the team to pull that for you.
It would be a lot.
Yeah, it would be significant.
Okay, thank you very much.
Thank you, Councillor Perks. Next I have is Director Bowery. And then for line of sight, following that, I have Councillor Wong Tam, followed by Director Sue Wong. So Director Bowery, when you're ready.
Morning, everyone, and thank you to all the staff for everything that you're doing, changing and pivoting on an hourly basis. I have a few questions with regards to vaccines. So, Dr. Davila, you talked a little bit about how supply is, lack of supply is overtaking sort of lack of capacity, because we have capacity to mass vaccinate our citizens. However, something else has come up in the mass vaccination work that I've been involved with across the city, and that is that, I mean, I'll give you the example of Easter weekend, where we were anticipating 900 patients to come in for vaccinations. And in fact, over 200 patients didn't show that day. And that seems to be a consistent story across the board in the larger vaccination clinics. And I understand that this is because we have people who are booking multiple vaccination slots at different sites and then not showing up at 4 out of those 5 sites are not canceling those bookings, which seems like a big administrative issue when we're looking at, you know, clinics that have vaccine supply and just need patients to put, you know, needles into arms for. So I wonder if there is a systematic change that can happen to address this particular issue.
So through the chair, certainly one of the opportunities perhaps is to have everybody on a singular booking system, because then it would be patently clear. You know, you wouldn't have to book in multiple places in order to get a spot to get vaccine. And, you know, I suppose if I was to look at it on the bright side, at least people are interested in getting vaccine. So they're seeking out opportunities to get vaccinated and perhaps booking more often than they should, you know, waiting for the first one to come up and then taking the opportunity to get that vaccine without necessarily canceling. But certainly one of the opportunities I would think would be, you know, having a singular system for booking. I would say this, though, with the increasing eligibility criteria that have been put out in the last few days, we're finding that more and more, you know, spaces are filling up. And our experience, I can say, within the TPH city-run clinics, we're not seeing as much by way of no-show rates as we might have even as recently as a few weeks ago. So, you know, my hope is that we will see less and less of that issue, but I would offer that perhaps the singular booking system might be one way by which to address that.
Good to know. The other two are about vulnerable populations. So I have been approached about clarifying the process for undocumented migrants, often who are working in high-risk settings and living in high-risk neighborhoods, and what the process is available for vaccinating them. There's a lot of fear around them coming forward and asking for vaccines when this might flag them within the system.
Yes. So through the chair, I can certainly appreciate that, and this has been an issue of concern for us as well. And in fact, you know, I'm happy to say that we are amongst the health unit or public health partners that raise this to the attention of provincial counterparts to ensure that there would be a system by which those who are undocumented can actually get access to vaccine. So short version of the answer, we are working with community agencies. That work is underway right now in order to allow for opportunities for people to get the necessary COVAX ID. I don't want to get too technical, but you need to have a special number in order to be able to book an appointment. We're working with our community agencies who work with populations who are undocumented and have status issues so that they can help provide those that COVAX ID so that they can book appointments. And as well, in the meantime, we are you know, taking names through our hotline service right now until that fully gets launched so that we can then share names and make sure that people are in the system and able to access vaccine, regardless of their status or documentation situation.
Perfect. I know I'm out of time, so maybe I'll do round 2 for the rest of my questions. Thank you.
Next I have is Councillor Wong-Tam. Councillor, when you're ready.
Great. Thank you so much, Chair, and thank you for all the work that Toronto Public Health staff are doing. My first question is to Dr. Davila. Dr. Davila, in Ward 13, Toronto Centre, and I don't expect you to know the answers to everything. I'm going to ask a very specialized and local question just because it came up over the weekend and last week. There are 2 sets of hotspot postal codes that are circulating right now in our local community. And I recognize that obviously much of this is coming by way of the announcements from the province made last week. One set of postal codes, and the 2 sets of postal codes, I should say, do not entirely line up. So my understanding is that the pop-up clinics that are now operating at Regent Park as well as Wellesley Community Center are accepting vaccination appointments for those that meet the criteria of the postal codes who are over 18. But that is not the case for the larger vaccination program. Do you know when, or if the province is giving you any indication when those two sets of postal codes may line up?
So through the chair, Councillor, so is it about the postal codes or is it about accessibility to clinics for 18 years of age and older? So right now, the way it works is with the postal code, the hotspots is identified by 53 different postal codes. It's actually the first 3 digits of postal code. Mobile and pop-ups are operating and can provide vaccines in those areas to 18-year-old plus residents.
Yes,
and
I understand.
So there's that. And then for the mass immunization clinics, which are on the provincial booking system, for those hotspot areas, those very same forward sortation areas, it's for 50 plus.
Okay. And then my understanding is that, for example, St. Michael's Hospital is using a different set of postal codes and a different set of criterias. I guess my question is, because there seems to be a number of different criterias and postal codes that are floating about, all within the same ward, is there a way that moving forward we can streamline this better? Just because there were a number of questions that came flying in from members of the public and local community when the province made an announcement that they were going ahead to vaccinate the 18 plus hotspot postal code areas, but none of us on the ground really knew much about it. How can we avoid that confusion again in the future is really my question.
So through the chair, first of all, Councillor, I would say that the postal codes are actually public and they are on our website. So that might help to provide some clarity. However, I think when it comes to streamlining communications, I agree with you. There are certainly opportunities for improvement as the announcements have rolled out fast and furious. I think there's an opportunity to, in the follow-up to really become far more focused. And I will tell you this, that we are constantly in communications with our healthcare partners and seeking to pool our resources, including those for mobiles and pop-ups, to start to focus on certain neighborhoods in a more coherent and collaborative way. I do think that that's how we will get the best out of our shared resources, which are limited by supply at this point in time. But in order to get the greatest value, we think if we concentrate and collaborate together, that will be most successful in mitigating risk.
Okay, thank you very much. And I have a question regarding taxi drivers, especially given their role in the pandemic, ferrying passengers and patients to and fro from assessment centers and hospitals. I see them almost akin to frontline healthcare workers, given their proximity to the patients. Would you classify them as akin to frontline healthcare workers, or do you see them more as essential workers?
So through the chair, Councillor, I believe the way it works within the provincial prioritization framework, and I admit I'm going off my memory, which is clearly suffering a little bit, but they're under the cannot work from home category of workers under that provincial prioritization framework. I believe this group of individuals would be in the transportation worker section. So it is covered within those essential workers. I'll just refer to any of my staff if I have misspoken. Please pipe up, but otherwise, if I'm correct, we'll let that stand. That's my understanding.
Thank you. And I guess because some of the taxi drivers are also ferrying those who are sitting in, obviously in wheelchairs, it means that they're not able to stay safely behind any type of plexiglass. They have to help them board and deboard. So they're in direct contact with the patient that they're taking to the hospitals and assessment clinics. So I guess what my question for you is, if they're in such close proximity to the actual patient or the person that's actually going to the assessment center and hospitals, Is there a way to actually reclassify them as frontline healthcare workers or akin to healthcare workers?
So through the chair, councillor, that would actually have to be directed towards our provincial counterparts. I would say this though, certainly making sure that they are using appropriate protections for themselves and that their clients are also appropriately masked would help. And obviously minimizing the amount of contact to the greatest extent possible will also be important. But as I understand it right now under the provincial framework, their expectation is that they will start these essential workers in May.
Thank you.
Thank you, Councillor Wong-Tam. Next, I have Director Sue Wong.
Thank you very much, Mr. Chair. My question is through you to the Dr. Davila. Dr. Davila, thank you for your presentation and your team. It's been exceptional work as always. My first question is related to the registration of the vaccine. On your slide 22, I believe is one of the recommendations you asked about the registration to the vaccine. How difficult or how easy it is for the City of Toronto have our own dedicated one registration center? Is that possible? Because we heard earlier from other speaker about the concern about registration. And I hear other municipalities having 5 or 6 different ways to register. How difficult is it for the City of Toronto to have our own?
So through the chair, very briefly, this was looked at very carefully by our colleagues in the immunization task force led by Chief Pegg. And certainly we were active participants in that. The determination was made that it made much more sense for us to participate on the provincial booking system, which is why we went that way. So I recognize that other jurisdictions chose a different path, but for a city of our size and our complexity and the number of mass immunization clinics that we were opening and the various offerings that we would have around the city, we really felt the provincial system would serve our purposes better.
Okay, my next question to you, Mr. Chair, to staff is related to the question, one of the witnesses before us dealing with the shelter data. I believe Kathy Crow in her presentation talked about the lack of shelter data. Can one of the staff answer my question? How difficult is it to get data related to the shelter, particularly about the workers? Because this is a vulnerable sector, and how difficult is it for us to get those data to ensure that we provide some direction and also policy for the board?
So through the chair, I believe that the request or the issue that was raised was in respect of delineating staff cases in the context of an outbreak relative to those that are perhaps of clients. And the issue is really one of personal health information and protecting privacy. Some of these shelters are actually quite small, and it would be readily identifiable which staff person we're talking about. So that's really the challenge here. And I appreciate and understand the concerns and how that, I think Kathy raised some very important concerns, and I certainly thank her for all her work and advocacy. But when it comes to this particular issue, we do have an obligation to protect the privacy of those individuals, and certainly small numbers for many shelters means that they would be identifiable. But they are included when we look at the total numbers when we report on cases within the context of those outbreaks.
Okay, thank you very much, Mr. Chair. Those are my questions.
Thank you, Director Wong. Next, I have Trustee LaPredi.
Thank you so much. I'm going to keep my video off because my kids are all home from school while I talk. My question is regarding the mobile and the pop-ups once we're able to start booking for 18 plus in hotspots. And I'm wondering if how we're going to communicate to those areas, because we're with the school board. I'm going to speak on behalf of the TDSB and I believe the TDSB, because we're on the same page on this. We have access to various amounts of families that are directly impacted by this, and we also have resources centrally and locally to reach these families. How is the communication going to be rendered to the school board so that we could effectively communicate this information to our families?
So through the chair, I will just highlight the fact that when it comes to the mobiles and pop-ups, the advertising, if you will, for those particular clinics tends to be quite focused and very much, you know, an on the ground and a little bit of a word of mouth approach, simply because they would be overwhelmed for sure by people who may or may not form part of the population of interest. However, I will say this, Trustee, the community agencies with whom we work are certainly a key partner there, and are making sure that you know, the appropriate you know, local agencies, presumably some of which would include school, are informed in a way that we can actually deliver vaccines in that focused and that targeted way to those who are at highest risk and to whom that clinic is meant to address. So happy to take this offline to see if there is something that can be done as we move into certain communities, whether there's an opportunity to connect with schools. But I think, again, we're working with our community agencies and our healthcare partners to focus these clinics in a manner that delivers the best in terms of need and gets to those who are most vulnerable.
Thank you for that. And my second question is regarding next year, actually, 2021, the 2022 school year. We've used a significant amount of our reserves to plan as much as we can a safe school year for 2020, 2021. I think that we use most of our reserves in order to plan that. And we're entering budget season right now with absolutely no recovery funds available. And so it's making it very difficult in order to understand how we're going to plan the 2021, 2022 school year. Are discussions being made with the school boards right now as to what Toronto Public Health wants to see done in our schools so we could plan appropriately?
So through the chair, it's my understanding that the conversations are actually first happening at the provincial level, certainly with the Ministry of Education and the Ministry of Health. And then we anticipate that there should be subsequent conversations happening at the local level. But it is, I have heard quietly that there are provincial level conversations happening, and that makes good sense to me. I think that establishing standards at that provincial level is probably a good first step, and then engaging local school boards and local public health at the next tier seems to be the next step on the agenda, but I haven't heard specifically about that.
Okay, thank you so much.
Thank you, Trustee LaPretti. Those are all the members of the board I have for speakers. Now, I would just note we're coming up on noon, and I'm aware that we will, as of 12:30, lose quorum at the lunch hour. And so we do have one more item with two deputants registered. So I'm happy to open this up for a second round, but I would just request members of the board to try to limit your questions if we will be able to conclude the meeting by the lunch break. So is there a request for anybody with second round questions? Okay, I see Director Bowery and Councillor Wong-Tam. Are there any others? Sorry, I'm doing my usual scroll through. Okay, Director Bowery, when you're ready.
I'll try and make it quick, but it is a hard question. Sorry, Dr. De Villa. You know, a few weeks ago, we were talking as a primary care provider. I had great dreams that AstraZeneca would allow primary care providers to really participate at a grassroots level in providing vaccinations for our patients, largely because patients, I don't think are hesitant as much as they have lots of questions that they like their primary care provider to be able to answer and provide security for them in going ahead with the vaccination process. And now with the restrictions that NACI has put on sort of the age group that AstraZeneca can be used on, and the vaccine hesitancy that has resulted of those restrictions, what do you see the role of primary care providers being in the immediate future with regards to supporting the vaccination initiatives that are already in place?
So through the chair, as per the provincial government's plan and their rollout, primary care providers are participating using the AstraZeneca. A limited number of primary care providers are participating in the AstraZeneca program. The vast majority of AstraZeneca is going through the pharmacy program, and that's as per the provincial government, and a smaller proportion is going through primary care. That is my current understanding of what their intention is right now. Dr. Bowery, I'm happy to speak to you offline if there's interest. I understand that we are receiving requests from primary care practices to participate to the extent that there is AstraZeneca to be delivered. And we do have a mechanism by which to help sort that through. So very happy to discuss that offline if that's of interest to you and your colleagues.
Any follow-ups, Director Bowery?
Nope, that's it. I promised it would be quick.
Thank you. Councillor Wong-Tam.
Yes, thank you very much, Chair. And through you to Marianne Bedard from SSHA. I am aware of a hotel called the Don Valley Hotel. It has 353 hotel rooms. It sits on just about almost 6 acres of land. And I understand it's actually vacant and it's pending development. And so there's an opportunity to pursue this hotel for hotel shelters, given the crowding capacities that we're certainly experiencing in the shelter system. Is SSHA aware that this hotel is available, sitting vacant, and have you tried to pursue it?
Councillor, yes, we did try to pursue it twice last year. Initially, we were put in contact with the hotel owner by a mutual third party who knew that they were interested, and we began some negotiations with the hotel owner. We weren't able to pursue those negotiations. The owner said that they were no longer interested. But then they reapproached us in December of last year, and we entered into negotiations again. And then shortly after, within a day or two, they pulled out.
And did they give you a reason as to why they pulled away from the negotiations from the city, considering that they have a very large empty building that could be a hotel shelter?
They didn't give us any direct response. They just said that they were in a difficult situation and that they weren't able to pursue a contract.
Do you find it strange that they would contact you in December and then about 24 to 48 hours later turn around, tell you that they're no longer interested in talking to you?
It was disappointing, Councillor. It was a great opportunity because the site is going for redevelopment. So it was one of those locations where we wouldn't have had to pay for refurbishment costs at the end of our tenure.
So it's a matter that the property was vacant, it's available, and we didn't have to refurbish the rooms after our use. So overall, it would have met the financial performance and the standards of what would be a viable hotel shelter for us. Is that correct?
Yes, Councillor.
Are you still interested in this hotel?
We continue to look for hotels, Councillor. One of the needs that we have at the moment is, as we're pursuing opportunities for housing and buying some of our hotel locations, we actually need swing space. So we need to be able to bring on other hotels that we can move people to in order to renovate current hotels into housing. So we're always interested, and CREM continues to look for opportunities for us.
And because the hotel has 353 rooms approximately, that would have solved a number of our existing challenges. Those who are staying in the encampments, those who are crowded in congregates, shelter settings, it would have actually met a whole bunch of needs and been a solution to that. Would you agree?
It did pose a great opportunity for us. It was also on a TTC line as well, which is always something that we're looking for.
Was the local councillor made aware of the fact that SSHA was pursuing this hotel?
Yes. If we think that the discussions around the lease are going to be productive, we do connect with the councillor to let them know.
Was the councillor supportive?
No, we did not get the councillor's support on this.
Okay, thank you very much for your answers.
Okay, thank you. Those are all the speakers I had for a second round. I have a couple very quickly on my end. Dr. Davila, you provided us 2 recommendations in your presentation that I will move on your behalf. One spoke to the need for more supply. So can I just understand, is it your opinion that the City of Toronto and our healthcare partners in the city require increased supply given our high transmission rates right now?
Briefly, yes.
Okay. And do we have enough supply currently to vaccinate all the recently prioritized phase 2 populations, such as education workers in hotspot communities and those over the age of 18 in hard-hit neighborhoods?
At this point, through you, Mr. Chair, no.
Okay. And then your second recommendation spoke to those who are over 18 in high priority neighborhoods and being able to access registration. By that, do you mean that in specific hard-hit neighborhoods, that people over the age of 18 would be able to register online through the central system? Is that what you're referring to?
Through you, Mr. Chair, yes, we'd like to open up the channels to those who are in the highest risk hotspot areas of the city and to do so broadly.
So those in the highest risk hotspot areas in the city over the age of 18, that they would be able to register online in addition to accessing a mobile or pop-up clinic that may come. Is that right?
Through you, Mr. Chair, yes.
Okay. And then there's been some discussion related to education workers and vaccines of early childhood educators and essential childcare workers. And there was, we've heard from some deputations here. Is it the position of yourself and Toronto Public Health that early childhood educators and childcare workers in those hotspot communities should be considered education workers like teachers and others and be able to access the vaccine?
So through you, Mr. Chair, we have actually advocated to our provincial counterparts verbally and indicated that it would be important to provide childcare workers the same sort of access as has been provided to education workers, particularly in hotspot communities. Okay, so you have Toronto Public Health has conveyed that verbally to provincial counterparts. So would you be supportive of the Board of Health affirming that same position formally as a board? Briefly, Mr. Chair, yes.
Okay, thank you. Those are all my questions. Members of the board, that now brings us into committee for speakers. I'm going to put myself on to speak. Can I do a speakers list here? I see Trustee Donaldson, other speakers. Scrolling through the list. Director Mulligan. Sorry, Director, I'm just scrolling back and forth. Okay, well, we will begin, and I'm going to put myself on first. I will begin by moving a motion here, and I will, if the clerks can put it on the screen, I will briefly go through the points listed. The first is for the board to reaffirm in the midst of the third wave the MOH's position to call for 10 days of emergency paid sick leave during this pandemic immediately. Also, I am placing the 2 recommendations our medical officer of health has recommended in her presentation moving them here for the board on her behalf. First, to call on our provincial and federal counterparts to increase vaccine supply to Toronto, given the rates of transmission and the number of priority populations in phase 2, such as essential workers and hard-hit communities. As well, calling on the province to, as our medical officer of health noted, to open up the registration system in those highest risk hotspot areas so that residents over the age of 18 can register and not be solely reliant on a mobile or pop-up clinic coming. Moving on, as our medical officer of health has conveyed verbally to the province, formally as the board, to call on the province to include early childhood educators and essential frontline workers in childcare as eligible as part of provincial plans to vaccinate all education workers in hotspot neighborhoods. And then finally, for our board, calling on Toronto Public Health and our immunization task force alongside our provincial and healthcare partners to put it bluntly, to use everything we've got, to put everything we have into scaling up vaccine delivery to those essential workers and residents in hotspot neighborhoods. And finally, here is to request our medical officer of health in consultation with Shelter Support and Housing Administration and our healthcare partners to expedite the vaccine rollout for those experiencing homelessness, to work to secure additional isolation and recovery locations, and to focus on immediate permanent housing options. And finally, as we've done before in the midst of this third wave, to request our medical officer of health, along with her regional counterparts in the province, to take any additional measures that she deemed necessary to stem the tide of this third wave. So that is a comprehensive set of amendments, both moving Dr. Davila's amendments as well as some of our own, and thank you to all who've been involved. A few brief remarks. Just first of all, thank you to the deputants who spoke here today, to Board of Health colleagues for all of your individual leadership and work, and most especially to Dr. Davila and her team. The presentation we saw this morning, and which builds upon the news we read and our daily experience, it's profoundly chilling. We are in the midst of a third wave with highly transmissible variants, and at the provincial and city level, we are on track to see cases and hospitalizations and ICU admissions unlike anything we've ever seen before. With modeling suggesting that at the current transmission rates, we could see 2,500 cases a day in Toronto by the end of April. And worst of all, our most vulnerable, those who are already marginalized in our city, are at highest risk, whether that's because of where they work or where they live or the absence of a home. And I know we're tired. I know people are exhausted. I know vaccines represent hope. And I know residents of our city are all collectively done with this pandemic. But this virus is not done with us. We have come too far, and the risk is too great for too many to not do everything we can right now to go hard, to go fast, to have no regret in limiting contact and supporting those essential workers who have no choice but to continue to have contact. And when it comes to vaccines, we know that vaccines alone will not stop this third wave. They may be how we beat this pandemic, but they won't stop the third wave. And so we must vaccinate the most vulnerable as quickly as possible. And that means allocating supply based on risk across this country and across this province. That means enabling those who are at highest risk in those hotspot communities to be able to register and access vaccines. And it means rolling out these vaccines with our provincial and healthcare partners into every neighborhood, in every community, in every language, to those at greatest risk today. And with that, I will thank you all once again. We will continue to carry through and fight through this. Next up, I have Trustee Donaldson. Trustee, when you're ready.
Thanks. So based on what I'm hearing this morning about the provincial vaccine booking system, I just want to start by saying that it's damaging for the province to announce a vaccination rollout with clearly not enough supply and a very incoherent plan. People in our city are desperate for good and reliable information, and I want to implore the province to do better And I want to thank Toronto Public Health for working hard to reach out to the provincial partners and continue to try and improve both the planning and the communications around this. I also want to say that I believe that the province abdicated its responsibility to close schools last week and forced Toronto Public Health into issuing a Section 22 order. That said, now that we're in a position where TPH has control over the dates of the order, and given this new information this morning that bookings for priority education workers are into May, I want to ask you and your staff to please provide as much advance notice as you possibly can to our students and their families. And finally, I want to take this moment to quickly say that I'm grateful to this board for adding early childhood educators to the advocacy for vaccine priority. Our children and youth and all of their adults, including the ones who work with them and live with them, have been so very resilient during this pandemic. And I know I say this a lot, but it bears repeating. Thank you to you and your staff, Dr. Davila, for continuing to keep schools that are the cornerstones of our communities at the center of your work and as a key sector for reopening, but only when it's safe to do so. Thanks.
Thank you, Trustee Donaldson. Next, I have Director Mulligan.
Thank you. Thanks, Trustee Donaldson and Chair Cressy. You know, I think at times Dr. Davila is in a difficult position, having to speak with technical precision and diplomacy in trying to outline the seriousness of the situations that we're facing. And so I want to thank the board for digging deep into the questions and really surfacing some of the key needs around making sure that our communities are protected and that our workers are not deemed, that we don't have workers' labor deemed essential, but not their lives. That we recognize as a board and as a community that none of us is safe until all of us are safe, and that it's in the city's best interest to vaccinate the highest risk people first and as quickly as possible. It's incumbent on us as board members to speak plainly at this time, to speak out about the risks, to encourage people to do their physical distancing and to recognize what's different about this wave compared to other waves. We really can't let up now, and I strongly encourage all of us as individuals and as a collective board to take this time seriously. Sorry, my kids are in the background. And to, you know, for those people who are working from home and have been for a year, you're not seeing some of these things in person the way you were before. And so I'm deeply grateful to those frontline workers from the housing sector, from shelters, from childcare, for coming in and reminding us of the significance of really prioritizing the people who need it most for our social cohesion going forward, that we don't end up in a situation where people feel forgotten or left behind, that we are still in contact with one another and still seeing one another as a community. So I just very much strongly urge everyone to continue. I know everyone's exhausted. I know TPH staff have been working very hard, and I want us to be very, very clear about the risk, about the need to intervene now, and about the need for us as a board to do absolutely everything we can in this moment. Thank you.
Thank you, Director Mulligan. Are there any other speakers on this item? Okay, seeing none, there is an amendment that was placed in front of us. I wonder if we, along with the staff recommendation, or there were no staff recommendations. So there is an amendment in front of us, with the MOH recommendations from her presentation included. So I'll call for a vote. All those in favor? Opposed? Councillor Longtime, your hand is still up. Okay, opposed, seeing none, that carries unanimously. Thank you. We now will move to our second item on the agenda. And before we do, just a thank you to all the members of both TPH for that item, as well as city staff from across the city who participated. We're now moving on to our next item, which is item HL 27.2, Advancing Black Food Sovereignty update. We do have two registered speakers. So I'll turn to our team at Clerk, ask if we can open up a line for our first speaker, Josephine Gray from the St. Jamestown Community Cooperative. Josephine, do we have you on the line?
To the chair, this isn't home with the city clerk's office. Josephine Gray is currently connected, but has not connected her mic in order to speak. Josephine Gray, if you could please connect in order to speak. Thank you.
Josephine, do we have you there? We can hear
Can you
you.
hear me now?
We can hear you
Excellent.
loud and clear. Thank you for the patience and for sticking with us. When you're ready, you can begin.
I had expected a report from the staff to precede my speaking. Was that going to be an agenda on the agenda?
The report is in front of us. There's no presentation on this item.
Oh, okay. Well, I can't see it. But anyway, I apologize for not having seen the report. I was hoping to respond to it, but I will just say that speaking from St. Jamestown, which has roughly double the population of people of African descent and is facing a dire emergency around food security, our biggest challenge, as faces many organizations, particularly Black-led and Black-serving across the city, is to access space. I know that there's a lot going on and we're all juggling, a lot of issues in the crisis with very insufficient resources, particularly for senior levels of government. But I think in this particular case of trying to advance Black food sovereignty, this may be an important opportunity for us in civil society and you in the civil service and political leaders to work together to try to get the senior levels of government to take our issues more seriously and allocate more resources. We know that the provincial government is sitting on federal COVID funding that hasn't been allocated. We know that the federal government has money to help to retrofit, upgrade, and clean up spaces that could be utilized for food security work. Many people in our community firmly believe that a healthy diet is an incredibly important part of fighting COVID. We do have, more than our share of essential workers in our community. In fact, more of our residents are employed on average than the city average. And it should also be noted that more of our residents are highly educated, roughly 49% than the city average. So we have a very unique community in St. Jamestown that has dedication now to Black food sovereignty and Indigenous food sovereignty. And it needs to be noted that the Black community, the African descendant community in Toronto is very, very diverse. And St. Jamestown is an excellent example of that diversity. And we need to be able to work across many different faiths, languages, lengths of time being here. We've got everybody from East Coast, Mi'kmaq, African descendants living in St. Jamestown, up to a recent wave of East African refugees. So we need some substantial support with both translation and secure resources and wages for staffing to be able to respond to the crisis of food security in St. Jamestown in general, but recognizing that people of African descent are more likely to also be facing hunger and COVID. I think it's a really critical site and a really critical community to be addressing as soon as possible. And we, of course, stand in solidarity with people working on Black food sovereignty across the city and are very aware from our partnership work with the African Food Basket and the Black Food Sovereignty Initiative that we're facing these kinds of struggles across the city. We also are aware that the province has more power to commandeer infrastructure, open up spaces, et cetera, than the city does. And we would, offer to stand with the city in challenging the provincial government and the federal governments to do what they need to do their duty of care, to invest our public resources in this emergency and ensuring that those most affected and most impacted have equal access to healthy food, to vaccinations, to space to do the community work, to help each other survive the many, many ripple effects and damage being caused by COVID. I will say that in St. Jamestown, overdoses have increased by 162% over last year. We're seeing a lot of body bags come out, suicides, people dying alone, etc. So please consider St. Jamestown as an emergency, but also a place where we can really get to work on Black food sovereignty and help spread our learning and our experience and work with others across the city to engage in making Black food sovereignty a reality. It really matters that we are able to access and eat healthy food, especially when so many of us are on the front lines doing essential work. And I really hope that the Board of Public Health can do what it can with other departments of the city and senior levels of government to really focus and collaborate and cooperate on an urgent response to the need for Black food sovereignty.
Thank you very much, Josephine. I'll open it up to see if there are any questions for Josephine. Seeing none, Josephine, thank you very much, and thank you for your patience to stay with us all morning in order to provide those important remarks. Our next speaker is Zakia Tafari.
Might I see that report?
I'm sorry, I didn't hear there. I think that may have been Josephine asking where she can access the report, which is available online at the City of Toronto under the Board of Health agenda, and we'll make sure that that's sent to you directly if you cannot find it. Our next speaker is Zakia Tafari from the African Food Basket.
Hello?
Is that Zakia?
Yes.
Welcome, Zakia. Thank you for being here. You have 5 minutes and you can begin when you're ready.
Can you hear me?
We can hear you, yes.
All right, so I want to thank the board for allowing me to speak here. I am filling the place of Anan Laloli, the executive director of the African Food Basket. He was unable to present due to unforeseen circumstances. So the African Food Basket is a Toronto-based nonprofit organization that has been at the forefront of championing food justice and food sovereignty in Toronto's African Caribbean Black community since 1995. Before moving on, I would like to acknowledge the hard work and dedication of the Black Food Sovereignty Working Group, which is made up of community members, food activists, students, chefs, farmers, academics, and food policy analysts. We would also like to acknowledge the support of Ryerson University Studies in Food Security Center, the Network of Advancement of Black Communities, and the Caribbean African Canadian Social Service community members. The African Food Basket has long championed food justice, and when the COVID pandemic hit, we were well positioned to support the African Caribbean community by establishing a program called Black Food Toronto, which focuses on addressing food insecurities, which have been impacted at almost double the rate for members of the African Caribbean Black community. I believe the development of a Black food sovereignty plan that provides a comprehensive approach to address the chronic food insecurity faced by the African Caribbean Black residents through addressing systemic barriers while increasing opportunity and ownership over local food systems is critical and imperative. More specifically, the Black Food Sovereignty Plan is said to work to advance 3 interlocking goals: developing city-supported Black-led initiatives dedicated to addressing food insecurity issues that disproportionately impact Black communities, identify and establish sustained supports and funding for food-focused, Black-led, Black-serving, and Black-mandated organizations and Black food sovereignty community infrastructure, and engage, align, and leverage new and existing city strategies and initiatives to advance systems change and shared goals to realize Black food sovereignty outcomes in Toronto, in neighborhoods throughout Toronto with high Black populations. Since May, we have served over 1,500 households who have requested emergency food support. We've done so through the support of community partners across the city, including community health centers. We have provided fresh, culturally sensitive fruits and vegetables to vulnerable members of our community. We provide food baskets to community partners who have and continue to provide food support to members of the African Caribbean Black community who have been financially impacted by the effects of COVID-19. We also provide food support to undocumented members of our community, which we found is a high number of seniors in many low-income communities in Toronto. Through our partnerships, we have also delivered over 3,000 vegan meals to seniors and provided ongoing food rescue of non-perishable items and donations to us. Our organization provides volunteer opportunities to over 68 individuals, which include youth and seniors. And throughout our endeavors, we've provided over 7,000 PPE kits to support members who need to go out into the community and want to do so safely. Many clients who have received an emergency food basket from us are seniors age 65 plus, or single parent households, or large families with children and youth, many of which have only received one emergency food box from us due to the high need. Over the past 5 months, we have seen an increase in referrals from community organizations and our registration being circulated online via WhatsApp and Facebook. Every time there is an emergency lockdown put in place, we see a surge in people applying for our support as seniors are fearful of going out and contracting the virus and want to stay safe. We cannot continue to do this work without we can't continue to do this work effectively without sustained support and funding. We believe that it's imperative that the city provide financial support and support mandates that move forward the agenda of Black food sovereignty and empowering organizations of the Black community to provide that support. There are endless studies that show that food insecurity furthers social determinants of health and ultimately impact the health and well-being of marginalized residents. These impacts will cost taxpayers for years to come. We believe that early intervention is critical. We are in support of the development of a Black food sovereignty plan that is comprehensive and well-resourced. We feel that Black food sovereignty is a timely and critical need for our community, especially as COVID has both disproportionately impacted Black communities in our city and brought into sharp relief the inequitable gaps in our food system. We believe that it's imperative that the city support this, this recommendation. And sorry, I'm missing my notes. And move forward with supporting Black food sovereignty. Real quick, I'd just like to share some statistics that we've collected from participants.
And I'll ask, you're just over 5 minutes, so I wonder if you could summarize the statistics in a concluding sentence or two.
All right, so I'll just say quickly, 62% of the families who have applied to us are unemployed, 37% are families who are employed, and we've seen a large majority of families who've requested support to us are on Ontario Works. Thank you.
Thank you very much, and I'm glad we did get those statistics. So thank you for that. Are there any questions from members of the board? Seeing none, Zakia, thank you very much. We'll move this into committee. Just before we do, we're just coming up on 12:30 and I need to move a formal motion. I'd like to move a motion that we continue to complete the agenda as we are just about finished. So if our clerks can move that motion, that the board extend its meeting past the scheduled 12:30 lunch recess to complete the agenda. Thank you very much. All those in favor? Opposed, if any, that carries. Okay, we'll now move this into committee for questions of staff. I notice we've been joined by Denise Campbell, the Executive Director of SDFA. I believe we also have staff from the Confronting Anti-Black Racism Unit as well. Councillor Wong-Tam, yes.
Yes, thank you very much. And thank you, Denise, for this excellent report. I'm very encouraged by the work that is ahead. With respect to Josephine Gray's deputation, I'm not sure if you heard her speak from Oasis. You did, okay, great. So there's a desire to work in St. Jamestown and to actually help Oasis accelerate their work when it comes to supporting Black communities in St. Jamestown. Is St. Jamestown to be included in the new work strategy around Black food sovereignty?
So thank you for the question, Councillor Wong-Tam, and it was great to hear Josephine. So staff from our Tower Neighborhood Renewal Office has been working with the St. Jamestown community prior to the work on the Black food strategy. Now that both things have are moving forward, we are looking to work with and talk to them around how we can better support Black residents within the St. Jamestown community to be a part of this process and ultimately to be beneficiaries.
Thank you. And in the staff report right now, it's the recommendation is for this board to receive the report for information. Do you have enough direction or actually it looks like you're not even looking for direction. You're just sort of informing us about what you plan to do. Is there are there timelines for a report back that you see coming back from the strategy? And is it going to be regular and frequent reporting?
So as Councillor Cressy noted, the Confronting Anti-Black Racism Unit within SDFA is a key driver of this initiative within the city system, working with African Food Basket and community leaders to better align our music to my ears actually, but to better align our work on confronting anti-Black racism and our reporting requirements. We are taking the report back on the overall plan to Economic Development Committee in September, and that will allow us to do the next steps that are articulated in the report. If it's the wish of the board that we come back at some point with an update once council has had a chance to consider the final plan, we'd be happy to do so.
Thank you. And my final question is with respect to benchmarks for success and outcomes, what would be the evaluation matrix that your team will be using to determine whether or not the program that you intend to set up is going to be successful? Is that going to be embedded in the work as well? Is that going to be developed along the way?
That will be embedded in the reporting on the overall plan. We will be building on the Ubuntu framework that we use overall to evaluate the confronting anti-Black racism work. And so that will be tailored specifically for this process, along with an community leadership evaluation table set up specifically for the plan that will help us to sort of round out the Ubuntu framework related to Black food sovereignty.
Okay, thank you very much. And I guess maybe one last question. Well, with respect to community engagement and working with the Black community, I mean, obviously there's not one neighborhood where they're concentrated. Everybody lives all over the city. How will you engage with larger populations of Black community members in the various neighborhoods across the city?
So obviously community leaders in Black community have been advocating for a very long time for the city to play a role in a facilitating role here. And so for us, focusing on communities with the highest populations of Black people, at least for the beginning and steps, is really important. So Jane and Finch, for example, will be a high priority area. We are, and we will, I'm just checking in with my team here, but we will continue through the Confronting Anti-Black Racism Unit and our community partnerships to figure out where the priority populations number of Black folks are, that we will focus on some of the early efforts. But ultimately, we want to be able to support Black Torontonians across the city, no matter where they live. But we do have to start with the highest, densest populations of Black people.
Okay, thank you very much.
Thank you, Councillor. I see Director Mulligan.
Thank you. I have a quick question. It's about, well, our board declared anti-Black racism a public health crisis last summer. So I'm wondering what's the connection between, if any, between that declaration and this work on Black food sovereignty, and what relationships would you like to see continue or grow between public health and SDFA in advancing this work?
So we definitely appreciate the leadership of the Board of Health in declaring anti-Black racism as a public health issue. It's part of the foundation and the framing and the opportunity we see to advance this work, and hope that we outlined and emphasized that in the report in front of you. We certainly see this as part of responding to recommendation 8 in the Confronting Anti-Black Racism Action Plan. And we, through the pandemic, have been working with Dr. Davila's team to keep food access and food leadership work moving by embedding that within the poverty reduction strategy. So our connections, I think, have certainly deepened between public health and SDFA over the throughout the pandemic to respond to the food needs of all Torontonians who are vulnerable, but particularly now seeing the opportunity to embed and advance this work focused on Black food sovereignty. So that's a long way to say say we thank you. It's absolutely critical and indivisible to the work of the Confronting Anti-Black Racism Unit. And as I said, based on the leadership, if there are moments where it's important for us to come back and provide updates to the work here at the Board of Health, we are happy to do so.
Thank you, Director. Any other questions from members of the board? Okay, seeing none, we'll move it inside. Any speakers on this item? Okay, seeing none, I will speak. First, let me move the staff recommendations in front of us, which are to receive the report, which we know a final Black Food Sovereignty Plan is coming in September. I think this board has been vocal and clear in its articulation that anti-Black racism is a public health crisis. And that manifests itself in many ways, including on the issue of food security. And that's what this report in front of us speaks to today. And let me thank our exceptional staff in Toronto Public Health who are involved, but in particular Social Development and Finance Administration and the Confronting Anti-Black Racism Secretariat for their leadership and hard work here. Black families are 3.5 times more likely to be food insecure than white families. That's anti-Black racism at work. That's structural racism at work. And so the SDFA Black Food Sovereignty Plan, which is being developed in partnership with and informed by Black food leaders and organizations on the ground, well, it's tremendously important. And it was important before COVID, but I will tell you, in the wake of this pandemic and the inequities that have been exposed and the issue of food injustice that is present, we must seek to address not only food insecurity, but anti-Black racism at all times. And so this update report today with the objectives in front of us and the work plan is a critical achievement and step forward. And I look forward to seeing the final plan being developed in partnership with communities on the ground coming this fall. And so with that, I will move the motion, the report in front of us. All those in favor? Opposed, if any, carries. Thank you. This now takes us to our final item on the agenda, which is it's a formal item because we need to formally give the space, but this is an update from Director Mulligan on the Association of Local Public Health Agencies, of which we, of course, are a member, and Director Mulligan is our board representative, to give us an update on, which we'll seek to do now on a monthly basis going forward, on most recent activities of Alpha. Kate, Director Mulligan, over to you.
Thanks so much, and thanks everybody. I'll try and make this brief because I know we are over time. The Alpha board is really important. It's a place where the public health units from across the province come together to talk about issues that are facing us together collectively as local public health across the province. And you've seen throughout the board meetings here how important the distinction is and the role of local public health is in the pandemic and across public health. So Alpha's been keeping the lines of communication open between health units and between the Chief Medical Officer of Health and Public Health Ontario and the local health units. We had our most recent board meeting just last week, and again, that was where the significance and severity of this wave was really impressed upon us again. So there's just one piece of information I really want you to have. One is that you'll be getting these Alpha information breaks so that you'll be up to speed on what's happening at that provincial level. And the other is to let you know that the AGM and general meeting is coming up. It's going to be on June online, co-hosted with the Northwestern Health Unit with support from the U of T's Dalla Lana School of Public Health. And the full meeting package and registration are available on the Alpha website and in that information break that you got. And the reason I'm mentioning it is that there's a lot of change in the air with respect to public health in Ontario right now, with respect to the pandemic and the inquiries that will follow, and the vision for the modernization of public health that was put on hold during the pandemic. And so Councillor Cressy and I have both been working hard independently to really elevate the work of boards of health during the pandemic. Councillor Cressy has been meeting with Board of Health chair colleagues. I've been supporting the Board of Health section at Alpha and community groups to make sure that boards are taking a really active role in ensuring transparency and accountability and representativeness and equity in dealing with COVID-19 and the ongoing repercussions of the public health measured. I've heard that other boards are registering for this Alpha conference and the AGM in full, like as full slates of boards. And so I'm encouraging our board to take an active role as well. Right across the country, our board is looked to as a leader when it comes to advancing public health. And there are impacts that we have made collectively as governors that are different, unique, and in addition to the very strong contributions of Toronto Public Health and the City of Toronto. And so I really encourage us to continue that leadership, to continue being a voice for the role of public boards, and to participate in Alpha. And so I'll be continuing to give those updates regularly at our meetings. Thanks, everyone.
Thank you, Director Mulligan. And if I could just add, Director Mulligan has been, and I've heard this from many colleagues across the province, a relentless advocate and champion for an equitable COVID response on our behalf at Alpha. And so just a huge thank you to her. Along with Director Mulligan carrying our banner at Alpha, I do want members of the board to know that I've been convening meetings with all the chairs of boards of health from across the province during this pandemic in recent months in order to both share best practices and address issues collectively. But I think, as Director Mulligan mentioned, when we beat this pandemic, and we will, we have a fundamental duty as local public health leaders in this province to, yes, address inequity, to, yes, build back fairer and better, but also to ensure that the discussions going forward around the role of public health, changes potentially to public health, need to be done in a manner that builds on our lessons and our strengths. And so that's going to be critical going forward. And that's why this work is so important and why we want to elevate it to a standing update from Director Mulligan going forward. Any other speakers? This was we do have to put it as a formal item, but it was intended to create a monthly platform to get an update from Director Mulligan on the emerging work. Any other speakers on this item? In the future, when we have more time, we will create the space for questions and all the rest, of course. But any other speakers on this right now?
Sorry, just on a point of order, Chair Cressy, will be sent the information on how to register for the June 8th conference?
Yeah, to members, you'll receive from Brent Gilliard in my office the details, both frequent updates from Alpha, but also details on how to register, if you'd like. Well, that takes us to the end of today's agenda. I know it was a busy one. It was a difficult one, both in substance and more, but I want to thank all of you as members of the board for your work, whether you're working on the front lines, like many of you are. Shout out to Director Bowery, who's been vaccinating people daily, I see from her Twitter feed. So whether you're working on the front lines or working behind the scenes, you're all playing your part. So thank you to each one of you, and to members of the city staff team who are here today, but especially our Toronto Public Health team, our heartfelt thanks for your relentless leadership. Thank you all. We'll chat again soon.
Thanks, everybody. Stay safe and well.